hospital plan development and research. He has led the integrated NCD management and had worked on models for population as well as implementation to the district level. And after his work from the WHO, now he is working as the professor in the Prasanna Institute of Public Health at Manipur. So, Dr. Varghese, welcome from the organizing team and for joining us in this workshop. Sir will talk on evidence-based management guidelines and its implementation from the global perspective. Welcome, sir.
Thank you. Good morning and greetings from Manipal. I was happy to join all of you. Thank you, Dr. Sekar, and I'm also very interested in the 5-day workshop, which is based on workshop on systematic analysis. I am at the Prasanna School of Publication. They are also provide detailed networks in systematic reviews. So this is something close to my heart. I hope you can hear me well and see my slides.
Yes, sir. The slides are not in slideshow.
It is not collection now.
Yes.
You can see my second slide.
No, sir. No, no, sir.
You see the second slide.
Sir, actually, it's in the slide sorter mode. Like four slides are synced together.
Oh, oh. Now,
Not really. It's honest. Um, slideshow, sir. Put it in the slideshow mode. Full screen to be
yeah,
shared.
here it shows a slideshow.
Sir, share your full screen. Then only we can not stop this present share first, sir, please.
Is it okay now?
No, sir, it's not. Sir, stop this sharing now and kindly share again with full screen.
Means we start sharing then. Uh, no?
No, sir. Still, it's same screen, sir. सर आप प्लीज अगर फुल स्क्रीन शेयर करेंगे तो हो जाएगा सर। अ, आप पीपीटी शेयर की स्क्रीन ओनली शेयर कर रहे हैं तो उसमें वो सेकंड स्क्रीन जो आती है स्लाइड शो वाली वो शेयर नहीं हुई है सर। ओनली द पीपीटी विंडो शेयर ओनली।
Is it okay?
स्लाइड शो में स्क्रीन बन जाए।
Sir, good morning. Sir, if you will send your slides to us by email, we'll display from here if possible, sir.
Yeah. You can share by looking so like this also. Selecting the modern things. It's working with this, so
No, no problem, sir.
the slides available.
एकदम full
Not the window.
Yes, sir.
Doctor?
Yeah. Yes. A full screen view. Yeah. That's
Sorry. Yes. Right, so not so important. I continue then.
yes. Yes.
Okay, so with whatever we can say, apologies for that technology fails in that we has to work. That also is an important aspect because systematic reviews are going to be through machine learning algorithms now. So in my previous 23 years of market research, quite a lot of my work was in guidelines, product and guideline review communication. Which is one of the agencies which produces guidelines. And these guidelines, as Dr. Faisal mentioned in the beginning, to translate it into evidence-based medicine is the challenge. Evidence-based medicine, I think you have very good sessions on that. It is really the history of evidence, the clinical judgment, with the evaluation of future values as based medicine, should then get into clinical practice. Was a conclusion before I was an oncologist. Like Saikat, I started my career as radiation oncologist. So I have seen the challenge in India in many other lower income countries is that there is absolutely no semblance to this standard protocol. Today morning, I sit there in the OPD, I get a breast cancer patient, I give one. Tomorrow, I see another lady, I give another protocol. In between, I went for a CME and I learned something, I just start. This is in summary what is the usual practice. That is what we have to change. So we have to apply relevant scientific evidence, which all of you are bringing out of your systematic reviews, and use the patient's condition and apply a standard treatment protocol. It should be the same. In fact, in most of the high-income country settings, any deviation from a standard treatment protocol is a clinical trial. That is the right approach because a clinical trial starts when you are not sure of anything. If you are sure of something, that becomes the standard treatment. When it becomes unsure, then you go into clinical trials. We should have a clinical trials which will also bring out the person. Something I wanted to make a point. Many of the systematic reviews that we do from WHO, if and when it becomes down to something like 6,000 papers and maybe 2,000 papers for full reading, 1,990 papers will be from high-income countries. And then what is the evidence for? The evidence is from low and middle-income countries. And then we something called conditional recommendation, which nobody reads. So these are some of the backgrounds that I just wanted to keep. It goes without saying that evidence-based medicine, if you practice, it can actually reduce the length of stay, and reduce mortality, reduce sometimes so there's been very well proven that evidence-based practice is what is needed for health systems. And the way we have to move into in India, starting from AIIMS Bhopal. What are the challenges here? When you come a systematic review into evidence, I'm sure you have a session on grade and other topics now. One of the challenges is conflict of interest. This with due respect to everyone in the room and in the clinical fraternity, pharma companies have got a huge influence, including when experts who are coming to the WHO. In fact, it is very difficult in WHO to the global experts who are not funded by pharma. The moment they are funded by pharma, then it becomes quite challenging because it may not be an over influence, but it will be a very subdued influence which will actually shape which example, how do you decide the outcome of drug? That is 3 month progression free survival. Even paracetamol also in cancer, you get the progression free survival sometimes. But, can be major thing when it six new molecules can come into the cancer medicine armamentarium, giving a huge cost to the patient and to the system. And see, pharma companies sponsored over 1 million events for US health professionals in a single year study. Okay, so that is the level of influence. So one of the things when you move from systematic review and evidence to guideline is to look at how good is the guideline. And perfect is not the enemy of the good. So this is a guideline that I developed for the pharmacological and radiotherapeutic management of cancer and advanced syndromes. There is this very big issue about should we just do a single fraction radiation or multiple fractions. Single fraction has slight excess risk in terms of cancer and other things. But if you look at the overall balance of evidence and the other factors of brain system capacity, that even stage one cancer has to wait for 6 months in some of the leading cancer centers in India to get radiation. We should really be very practical. So we suggested to give a recommendation that we are numbers including adolescents with brain disease metastasis. Those radiotherapy should be used when radiotherapy is indicated and available. But it is a strong recommendation with a high quality evidence. And this recommendation applies to people who already have bone metastasis. It does not lead to improve bone metastasis are not painful. So that means it is an improving factor. And then, it is a very defined window. So that is one very important thing. You cannot have guidelines which are broad and sort of sweeping guidelines. You have to be very clear. One is about being very clear. And the other is about guideline and it is a drug and no specific matter. Many countries have worked in so many countries. We ask the government, do we have a guideline? Oh, yes, we have a guideline. Bring the guideline. That will be some document written by 70 professors. That is fine. That is a license textbook of medicine. I just not want a protocol which is work and or specific for hypertension in the primary health care, where an average doctor or a nurse can practice a very simple. Nothing that simple is the most difficult part. So we can say we made a good guideline, but the user will say simple protocol that helps you to apply the guideline in my clinic. Clinical guidelines, of course, I'm not going into the details. You have to look at the validity, reliability, reproducibility, clinical applicability, feasibility that is allowed within that the of guidelines. So, one example of hypertension. So, I have been sort of instrumental in developing this novel hypertension initiative in Geneva when I was working there. So, hypertension control rate. The control rate among treated people with hypertension it is only 15%. That is actually a big hit on the health system, right? On all of us. Worsen cheapest medical condition, cheapest medicines, easiest to treat, wide on treatment in our health system. Out of 100 people who are treated, after 3 to 6 months, only 15 of them are getting and 140, 90. There's something serious that we have to look into ourselves. So that is why the major hearts package was formed. And this is the story of hypertension. People issue does not, they come, they are not being fully evaluated, full business. Given time, we given metformin 1 week and you come back, the patient will never come to 2 years. The patient was things are not good, things are good. To AIIMS Bhopal, he used to have a stroke and ends up in paralysis. And this is a system that we have, and this system has serious implications where we can actually evaluate at various levels. So that is why I developed this heart package, which is a package for the state counseling, evidence-based programs, that is the EMRs, brings access to essential medicines and technology, is team-based care and systems for monitoring. Systems for monitoring is which is classically absent in most of our health facilities. Of course, immunization and maternal child health good monitoring, HIV, TB also, because they are centrally funded, globally funded with dedicated programs. India's health profile has changed, and large number of conditions go into a health facility and say, what is your control rate of diabetes? I don't think any PHC they can say that in India as of now. So that is the level at which we have to move to. Of course, a lot of developments are there. The comprehensive primary healthcare solution is being applied, but we need to focus on systems for monitoring. So we developed in WHO a 61-page guideline, but we also developed a one-page specific protocol for hypertension. This is a very good example. Now, most of the clinicians are very resistant to change. I'm treating like this because that is in my head and that is what I want to change. And it is very difficult. They are not understanding that things have changed. My outcomes are not good because the compliance is poor. I'm not escalating the dose. There is a lot of therapeutic inertia. Take a simple condition like hypertension. Almost two drugs is mandatory now. Almost all people with adults with hypertension. But if you look at prescription audit and clinical audit, you will see that the inertia is very high. So people are not moving into. So just wanted to highlight the fact that it is okay to have clinical guidelines, but using them is another challenge. But if you use it, what happens? So this is actually showing that the NY is the health and wellness centers. This is Punjab and Maharashtra and all India. In Punjab and Maharashtra and overall registrations, you look at the number of registrations from 2008 to 2021, wellness center proportion has gone up from at least than 10% to almost 30 to 50%. What does it show? Quality of support system, you can actually shift their hypertension need not be treated by being cardiologist in AIIMS. 80% of hypertension can be treated by PHC. Cardiologist time can be used for much better use with severe conditions. And we can avoid the crowd. If you assess a tertiary hospital, it is required between the practice. 30 to 40% of people sitting in a tertiary center are people those who could have been easily managed in the primary care if primary care was very. So what are the reasons to do that? You should have evidence based. So this is the shift in yeah. And second, the clean gap is the control rate. You see, from a 15% control rate to close to 20% become 45% 4 years. So it is possible. It is possible to have population-based impact changes in clinical management if you know system. Yeah, evidence-based. Remember that hypertension picture that I have shown, so it has to change to like this. It has to start from community where primary health care is people. What we need to make sure is that we should have SOPs, but more than that, we should have standard protocol based on systematic reviews which will produce evidence-based guidelines for our context, not for the context in Netherlands, for the context in France. They need to have based protocols which are applicable in Bhopal, in Trivandrum, in Kashmir, and in Manipur. And that is where we miss in most of the guidelines, including WHO guidelines, which I'm thinking of, because comes in those countries and have good and evidence. So that is why most of the time becomes evidence which is not applicable. Condition called elimination of cervical cancer, something which I was passionate about. I was doing this for quite some time. The 90, 90% of adolescent girls should be vaccinated with HPV vaccine. 70% of women between the age group of 35 and 45 is screened with ideally an HPV testing followed by cancer. 90% of women with cervical cancer should have treatment. So that by 2030, so that by 2060 or something, we can reach to an incidence of less than 4 per 100,000. And incidence is about 17 to 18 to 20 per 100,000 in India. So let's look at, and so WHO has got guidelines. So what is the guideline? Women should be screened for cervical cancer every 5 to 10 years, starting at the age of 20. The HPV test will be used. It's called high performance HPV test by age 75 and the collection everything is followed. Where are we? Infectious 5 and one screening is for cervical cancer 0.9%. Ever undergone a breast cancer screening 0.9%. So where is the guideline and where is the national program? So the national program is the evidence-based guideline. That is why we have to really make sure that our health system is ready. Clean and fit pregnancy. It's a clear specification for the women to invite women and eligible. What level of health system into the screening? Is it the PHC or the Taluka hospital or the district hospital? Do they have the personnel and testing capacity? Many people can they screen? Women or under women a day? Are they adequately trained? There is the treatment of pre-cancer. Training is not just applying some test, it is ensuring that the pre-cancerous condition is managed and the natural progression of the disease is about. Where will cancer be treated if detected? Who will come first? We know the impact of screening. References. There's a paper which came from I know many women, I'm sure you all know her, maybe she's from CMC Window, she has gone to Australia and they have done this strategies, implementation terms of HPV-based cervical cancer screening studies to cervical cancer in India is systematic. This is again a very clear example of a systematic review and how it can influence practice. What comes from this paper? Community-based HPV testing, including circulation, is feasible in India with more research needed on the population. For implementation research is needed on integrating HPV screening with existing health systems, feasibility of HPV test and models in data-driven planning, to follow up in low resource settings. So it is one thing to do systematic reviews to make sure that they actually contribute to national programs. Cancer treatment, it takes 10 months for a person with suspected symptoms to get clinical treatment of it. Okay? Because again, there is no systematic protocol for covering this person. Often cancer may not cause cancer, actually causes. And that is why in the UK and all, we have made cancer audit programs. In fact, the national audit of cancer in UK is something that I think Singapore should try in all our AIIMS hospitals and see what is the diagnosis in staging in age emergency admissions, what is the type of treatment that is received, what is the type of chemotherapy, for example, if it's ovarian cancer, what partner receiving platinum-based chemotherapy, what is the 1 year survival. So there are a lot of elements that we can look into clinical audit. The other thing is developing an yes. You all know about universal health coverage and this is the times specifically about insurance scheme and all that. If you want to use active health insurance, first is we have to define benefit packages. And that is again where systematic reviews and analysis and a treatment protocols to be implemented. Of course, it will do the delivery of services. Infrastructure and the presence of indicators to measure out. Third party audits. You know that in most high income countries, governments don't own health system. Governments actually purchase health services from providers. Government is the purchaser and regulator and auditor of health services. I used to live in Switzerland in Geneva for many years. But it is not the government of Switzerland which runs the PHC. PHCs and other things are owned by agencies and governments purchases those services and say that for this many population, this many services have to be provided. What is the cost? And then that comes with the insurance program. It's from the people and from the government, and then that is paid. It is paid as a third party audit always. So when if you want to have Ayushman Bharat 5 lakh scheme be beneficial, you need to ensure that that is actually done with the standard treatment. That the cost is contained, unnecessary expenses are not. Somebody is actually auditing that. You can also do impact assessment of policy. This is again something that we have done recently when I was in the Southeast Asia regional office. Again, various interventions, intervention is backward tax, then can see what is its impact in 2030 reducing premature mortality from non-communicable diseases. It is one of those. So we can actually say 4.6 billion deaths were about if you think, all that. So there are six more questions to balancing. Don't stop at systematic reviews. Got it into evidence-based guidelines, the clinical base of being evidence-based clinical practice. Ensure that it is practiced and practicing as support. There are indicators, monitor the outcome in those facilities, as well as finally the so that is the chain of events that we have to look at. So finally, I will summarize. Static reviews and meta-analysis should address locally and nationally relevant questions, not an esoteric question just because there is a lot of yeah. Findings should be tested and turned into guidelines and protocols. Impact assessment and health technology assessment has to be added on so that you can the most appropriate technology of services to ensure compliance and quality of as well. I'll stop with that. To tell me about your effort, show me your results is what I wanted to say. So thank you very much and apologies for my slides. Saikat, you can actually distribute my slides to all the participants. Thank you very much.
Yes, sir. Thank you very much, sir, for such an enlightening talk. And I think that highlights the essence of this kind of workshops that workshops will be only effective when these are implemented in the ground. So we can take a few questions from the participants, if any. So any of you would like to ask some questions?
Good morning, sir. And we just discussed your idea that collect the data and use for the benefit for us. As you discussed for the cervical cancer, we are planning to have a brain tumor data registry kind of setup and review of last 5 year details. And definitely, with your feedback, we will take all the points into consideration. What were the delays and what were the barriers? Were the patients in right time and whether anything would have been done so they would have seek the early treatment protocols at any point of time where they had a contact with the healthcare providers. Thank you so much, sir.
Very good. Exactly. At any point, very, very nicely said. At any point, a person interacts with a healthcare facility or a health provider to be a standard. I just wanted to give the example of our banks. Maybe all of you are youngsters. 20 years back, if you went to our banking system, it was such a mess. Nobody knows some counter will be there. I think it is. You don't even know, have to go to the bank. There are defined counters. There is a standard process. So standardization is the way that we have to really go.
Any other questions? If there are no other questions, then we will conclude this session. Thank you very much, sir, for joining us. And we would definitely look forward to host you here sometime in near future. Thank you so much.
Thank you. And congratulations for hosting such important and useful sections. I can keep going. Thank you very much. And all the best to all of you. Thank you.
That were informative to whatever extent. It's not about grasping everything. It is not possible for any of us, including ourselves. We too are learning every passing day, and the most important thing is at least take some good you know messages, try to apply them. I also believe that yesterday's session on statistics must have been really good. What we are doing now is that we've done everything. We devised a protocol that was based on our research question. We had our PICO. We found studies. We after we have generated all the data, we plugged in that data into a form. We synthesized it. After the synthesis, now what we have to do is we have to grade. So this session, followed by Pratap sir's session, we'll try to see how the grade is applied, and the second thing, how that can be moved to the evidence. This is the great approach to summarizing evidence. I do not have any significant disclosures. So anyone, like, what is a meta-analysis? Just to revise. I start. So the statistical analysis of a large collection of analysis results from individual studies for the purpose of integrating the findings. So this is the overall part. You might have seen a lot of places you find meta. So is meta. So if you look at the root that shows after that, that is transcending. over and above the other things. So that is a meta-analysis that is over and above the general analysis that you are performing. So whatever general analysis you're performing, if you're going beyond that, is a meta-analysis. So as has already been alluded to, it is an optional, not a mandatory component. And once you have this as a optional component, you cannot perform, you can go ahead with synthesis without meta-analysis. The scheme of presentation would stay largely the same. This is the specific chapter. You can scan the QR code. This is from the Cochrane Handbook of Systematic Reviews, which will directly take you to the summary of finding tables, how it is to be generated. It's just a part of the earlier QR codes that we had used. So if we look at the grade network, the most important thing is like what is the need of it. So the need is that you have paper. These are the PIs. Everyone says that my paper is the best, my evidence is the best. So you need to bring them all on a platform where you can compare them and then define, like, yes, the evidence is meaningful and whatever you generate is the certainty of evidence. Okay. Why we are saying so? This is a very famous cartoon on since that I figure there's a 40% chance of showers and a 10% chance we know what we are talking about. Throughout our workshop, we have talked of when you're talking of 10% chance, what is the level, the confidence that we have been talking of? Yeah, bordering 95%. So anything less than that, maybe in few places you may keep it at 90, but anything less than that does not give you the confidence. You are a family of five, you want to move out. This is the meteorological department which is telling it तो 40% ही चांस है और आप कितने कॉन्फिडेंट है मैं केवल 10% कॉन्फिडेंट हूँ अब आप क्या करेंगे फॉर 5 पीपल 5 रेन कोट्स 5 अम्ब्रेलास क्या करके कैसे अरेंज करेंगे यू डू नॉट नो हैड दिस बीन लाइक आई एम 95% कॉन्फिडेंट कि 40% होगी so at least you'll cover so what we'll take a couple of umbrellas a couple of shower caps and this would suffice. This is the reason why I need to have both the things. If you have an estimate, this is the 40% estimate. How confident you are is the confidence interval that we are trying to define. So we've been using this word, who is the user when you are generating the evidence. So we always talk about the end users. That is the most important thing. You as a PI can generate publication. I'm saying generate a publication because you might require it for your promotion. You might try to change something. For a policymaker, it would be different. For someone who wants to capitalize, like from a pharmaceutical industry, his or her motive will be different. So the best word that is used is who's the end user. Now, Oculus also generates a plain language summary. So that is for patient as the end user. This is the beauty. So whenever you're making a recommendation, you should define at what level it is hitting. The key information that we generate for the users can be defined primarily in three basic terms. What is the magnitude of evidence? What is the amount of evidence? And how certain we are that this evidence is true. Okay. So just as 50% chance of rain, but 10% we are confident. Had it been we are 95% confident, so you are like pretty much sure of that, yes, it would or it would not rain. When we are looking at the grade framework, you find a summary of findings table. So all of you must be having that paper on which we had conducted the workshop on ROB, the paper by Wagner et al. So if you have gone through that paper, you might have seen you find a summary of finding table that lists most of the things. How it lists, we'll go through. It presents the main findings of a review in a transparent. Okay, whatever it is there, आपने downgrade किया, upgrade किया, whatever it was, it has to be transparent. It has to be on paper. The format is structured. Why? Because whenever you are looking at a summary of finding tables, It should be clear in your mind that yes, this is the header, this is the footnote, this is the place where I'll find the absolute differences, the relative differences, and this is the grade structure. It should be a simple tabular format. So whatever outcomes you are trying to define looks at one question at a time in a single table. As we have discussed, looks at three basic things: the magnitude, the available data, and the certainty or the quality of evidence. In the CDSR, you would see, if you can open the paper by Wagner, you can see that it appears just before the background section. Why it is important? Even before you have entered the actual publication, this will give you a bird's eye view into what all is present. Okay, so this is an important thing. You can get a hang of what would be available in the paper per se. Each row that is present, it represents an important or critical outcome of interest out of that larger question that we had shortlisted. So in our case, we were looking at the cumulative or all cause mortality at 120 days. And our question was looking at steroids plus standard of care versus standard of care alone in critically ill patients with COVID 19. Isn't it? So we were looking at 120 days. Out of that, we'll shortlist and find out how did the authors go ahead and define the evidence. So this is a snapshot of the summary of findings table as it appears in the PDF. So if we look at the template, we say that it is structured. So there has to be a template when we are talking of a structure. The template is, it gives you a brief description of the population and setting, the comparators, whether it is experimental or non-experimental or standard of care. It lists the most critical and or important health outcomes. We had discussed on that day when we are talking of critical outcomes should be defined both for the benefit as well as for the harm. If there are adverse events, if there are harms, always consider harms. If someone says that if you take the COVID 19 vaccine, the chances that you might have myocardial infarction because of thrombosis is 50%, will you take this thing? You will not take this thing. And if this thing is not listed in the grade summary, this is a breach of trust. आप किसी को वैक्सीन लगा रहे हैं, दिस प्रोग्राम वाज रोल्ड ऑन, तब तक कोई एविडेंस नहीं था. Up over a period of time, immunogenic reactions, thrombosis, a lot of things have come up. And this was also the reason that you have the largest registry for the immune-associated reactions, that is, in our terms, which is also known as AEFI, adverse events following immunization. A whole registry has come up, and it is at the level of end user. Those who have got vaccinated, they can plug in their data. Does not happen in India. They can plug in their data that I received the vaccination. This is the kind of reaction I had. So this is the kind of transparency that we have to, we should like kind of strive to achieve. So overall, what is happening? We have to define those critical outcomes, and a maximum of 7 outcomes are permissible in this table. We have to define the measure. We talked about just for blood sugar, whether it is in gram, milligram, or millimole per liter, it has to be defined. The absolute as well as the relative measure. That is the reason I've written and. It is not permissible that you do not give the absolute measures, because terms may be in, for a non-statistician, that might not be better than a jargon. ये numbers हैं. So just as we see the NNT or NNH, the term should be absolute. The number of participants in studies, so that you can see that this evidence was generated from how many patients and from how many studies. अगर एक ही study है तो उसको meta analyze नहीं कर सकते, but उसके basis पे बहुत बड़ी आप guidance document भी नहीं बना सकते. The grade assessment overall, which is given, then you have the comments and explanations. So these are divided into the two parts, the 1 and 2 in the row, and the 9 explanations, which are known as the header and the footnotes. So when you go to your Wagner's paper, I go on to that paper, so all that part that you see above, that is the header, that gives you the research questions. This is the summary of findings, which says that we are looking at the corticosteroids plus standard care. Here you have the proper question: corticosteroids plus standard care compared to standard care for hospitalized and unvaccinated with a confirmed and suspected diagnosis of symptomatic COVID-19. So this actually has been our flow in the workshop. This is the PICO, the patient, what was the setting, the intervention, and the comparator. PIC. Then you have the outcomes. Why people have been hammering you like follow this format, because this is how you go analyze, find the evidence, search the literature. In these outcomes, you have each and every outcome of your interest. Our outcome of interest was all cause mortality up to 120 days. Since it has only three studies, would be easy for you to understand. That is why we are sticking to it. This is the risk with standard care. It was alluded to very nicely earlier also. We are looking at the control event rate. I'll touch upon the control event rate again, because this is very important and you should be knowing why it is important, if it is less or it is more. So these are the anticipated absolute effects. You have the relative effects, number of participants, the certainty of evidence, and the comments. The comments section is you have seen everything. Then what is the gist of it? If we look at the all cause mortality, we know the confidence interval is wide. You have a very low certainty. Anyone, you have this plus and minus sign. What is this plus sign known as? हाँ, नहीं, जैसे चार है ना, तो जैसे एक गोला बना है, उसके अंदर प्लस साइन है. व्हाट इज दिस नोन एज? वो कहते क्या है, सिंबल को क्या कहते हैं? सिंबल को क्या कहते हैं? इस होता तो उसके आसपास सर्कल क्यों है? So we know that this is a direct sum. This is known as a direct sum symbol. And when the evidence is high, you have four of them, and subsequently it goes down. I'll show you in the next slides. So this direct sum is, as you decrease the number of direct sums, the level of certainty goes down. So this is the importance of knowing. So if there are three, we say moderate, two, it is low, one, very low, four of them high. So the gist is that the evidence is very uncertain because it is very low about the effect of systemic or corticosteroids on all-cause mortality up to 120 days. If you remember this structure, then spending some time filling in this structure, because then things would be easy for you to correlate. So, as I said, this is the PICO which is there, and these are the footnotes. These footnotes, as I said, things should be transparent. If you are someone who's doing the systematic review, you cannot grade it something up or down on your own whims and fancies. So you have to write what you did and why. So it states we downgraded one level for serious risk of bias. That was taken by Dr. Neeraj. We had three studies: a study by Dalatifard, by Geronimo, and by Munch. So we downgraded one level for serious risk of bias because of partly deviating from the intended interventions, the selection of the reported. Then there's one level for serious inconsistency and one level for serious implicit. So this is the transparency parameter that you find in the footnote. This is another example just to show why we are always talking of the three things. So simply put, you are looking at the relative effect. This is the magnitude that you are getting compared to the absolute effect, the amount, number of participants, and the certainty, that is the grade. So you have covered all the three things. The risk of bias, the amount, number of participants, and the certainty, that is the grade. So you have covered all the three things. 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 So you This is the comparison of how the relative effect translates into the absolute effect. So I suppose this gives you a better idea into what it means कि 100 में से 41 जो पेशेंट हैं वो मर जाएंगे. This will only tell you about 0.75. हमको अगर डिनोमिनेटर नहीं पता, कंट्रोल इवेंट रेट नहीं पता, when you're getting the absolute numbers, you're getting a hang of it. If there is a medication which says if you give it to 100 people, is 90 would benefit. ये बहुत बड़ी चीज है. उसका relative risk कुछ भी हो सकता है, and that might be totally, just a piece of jargon for you. So if you look at the summary of finding tables and how the measure that you have taken is defined, this must have been taken up yesterday also. So for the dichotomous outcomes, SOF should provide a relative measure, and we know what are the relative measures: the relative risk, odds ratio, and the hazards. There is been some discussion on this thing just to tell you why we are using what. So just focus on these two columns, the odds and the relative risks. What you can find is as the difference is increasing, the frequency is increasing, the proportion with respect to the effect of intervention and control, the gap between the odds and the relative risk is widening. So why do we say that for rarer events or events where the prevalence or prevalence is on the lower side, otherwise you relative risk. This is the reason. If you or appreciate, if you can see that this is the relative risk, this is the odds. As the rate increases, the likelihood that the odds would overestimate the effect size is more. I'll come back to this slide, and you can see that the odds ratio is 7.45. However, the relative risk is 4.5. The gap between them widens if actual rate, depending upon the baseline risk. Another example where you can appreciate this till the time event rate is less. Might ask after what we should bring that odds is a better measure relative 5 or below confidence odds as the preferred choice. In terms of the measure, above that, the chances that or you should be using a relative risk are more. So when it is low, the event rate in the exposed group and the unexposed group, if you see, the risk ratio and the odds, they would be giving you the same information. As it widens, you can see the change. And what is happening? The odds are, when you're using the odds ratio, it is overestimating the effect. Okay. Now, how it translates into a sample size, that was taken very beautifully in the very first lecture by Pratap sir. Just need to see a couple of things for the control event rate and for a given relative risk. Just look at the numbers. The numbers are very high. Okay. What is happening is as the control event rate is, it is increasing. What is happening? That the sample size is decreasing. As the magnitude of relative risk changes for any given CER, the numbers are decreasing. Just to put in perspective, and two simple take home messages. Number one, as CER increases, that is more frequent events, the required sample size is for a given relative risk reduction. Larger relative risk values, that is a greater effect of intervention, require a smaller sample size at a given CR. Depending upon your condition, you can utilize that. So I summarize the summary of findings table as they are built around the assumption of a consistent relative effect. We have looked at the dichotomous data. Suppose you have continuous data. Depending upon that, you can use an absolute measure as a difference of means in your table. Reduce with more than one comparison. As I said, one comparison, one table. In one table, not more than 7 outcomes. Okay. So, with more than one comparison should include a summary of findings table, which is separate than that. So, in the table, in the paper by Wagner, we have seen that first summary of finding tables looks at one comparison, that is corticosteroids plus standard of care versus standard of care. The second looks at two different kinds of steroids, dexamethasone compared to thioprednisone. Okay. So now we touch on this was kind of a vlog looking at certainty of evidence. Okay. The Cochrane logo states we are looking at trusted evidence, informed decisions, and better health. Anyone can spell out what grade means. What is this acronym for? ये इसके components you can spell out. क्या होना क्या चाहिए मतलब you would evaluate something, you would recommend, you would analyze, है ना? These are the grades. These are the overall grades which are looking at start from the last. Looking at the evaluation grades may D for development, assessment, and the recommendation. Then you spell it out grades of recommendation, assessment, development, and evaluation working group to understand. Grow from Go from the opposite side. It's about the evaluating the evidence, development, assessment, and then the recommendation. So there are four categories. You define them in four categories: high, moderate, low, and very low quality. It also has its own set of standards. Whenever you go to RefMen, you have a complete, a help section. This help section is defined under the methodological expectations for the conduct, quoting, and updating of systematic review of interventions. In short, this is known as MESSER. So something we alluded to in terms of generalize कि मेरा evidence अच्छा है दूसरे का नहीं है. When we started the presentation, let us have an example. Most of you know about the global NCAP. So if you look at the global NCAP, you find grades. Now you do not go into the numbers. Is this vehicle rated for safety? The answer is yes or no. If it is rated for safety, then what is the evidence that we have? If it is 5-star, provide you a good protection. And what is this? This is the confidence interval. The score that if you generate this score, this will give you the boundaries in which their final rating comes. Say if it is say 14.5, it would be falling between 14 and 17, given as a good protection. They give you the parameters. ऐसे टेस्ट करते हैं पहले 56 किलोमीटर पर आवर था अब 64 किलोमीटर पर आवर है किस स्पीड से ऐसा नहीं है ना कि आप 200 की स्पीड पे गाड़ी चला रहे हो तो कोई भी गाड़ी है वो क्रश हो जाएगी तो एक स्टैंडर्ड था जिस स्टैंडर्ड पे उन्होंने इवेलुएट किया उन्होंने इवेलुएट करके दोनों को अलग अलग किया गाड़ी में जाएंगे अलग अलग जाएंगे तो लार्जली आपने डिवाइड किया लेट अस define the protection for the adults let us define the protection for the kids they give you a adult occupant safety and child occupant safety. Now, किस region को सबसे ज्यादा hit कर रहा है? Heads are nicely protected along with trunk, whereas the legs and the pelvis are weak or poor. So this is a very good example of looking at the grade. NCAP ज्यादातर सबको पता होगा गाड़ी खरीदने जाते हैं तो अब now it's kind of a norm that you try and buy a vehicle that is safer. When we look at grade, it consists of five basic domains. Everything from now on that you do, you will be requiring this thing. You have this thing in the chapter, probably chapter 14, if I am not wrong. These are the five domains in which you would try to assess the evidence. The first and the foremost domain has already been covered, but we'll still touch upon it so that it becomes, more concrete. That is the risk of bias. The second thing is inconsistency. It was touched upon in terms of heterogeneity, indirectness when we are looking at the PICO, imprecision in terms of the confidence intervals. Last but not the least, what is the publication bias? Out of these, the two things which generally lead to a lot of confusion is inconsistency and imprecision. After ROB2 is there, a lot of quantitativeness has been brought into from ROB1. So it might be, it might be giving you now a better, in terms of numbers, an assessment of how the evidence was. If you look at the grade approach, so if you have a paper, you write लेवल 4, यू स्टार्ट विद एक हमारे पास हमको एक पेपर करना है और उस पेपर के सामने जो सारा एविडेंस मिल गया उसको 4 पे आप रेट कर सकते हो, तो डायरेक्शन वुड बी 4 इन नंबर्स. दिस इज हाउ यू स्टार्ट. देन यू स्टेप डाउन एज यू आर फाइंडिंग द fallacies और deficiencies in the evidence. एक डोमेन में प्रॉब्लम लगी या एक डोमेन में लगा कि एक से ज्यादा है तो दो कम कर दिए. सो फ्रॉम अ हाई एविडेंस आपने दो कम कर दिए तो लो एविडेंस हो गया. एक और कम कर दिया, सिंगल रह गया, बिकम्स अ वेरी लो एविडेंस. तो ओवरऑल यू हैव 4. अब 3 से ज्यादा नहीं कर सकते बिकॉज यू कैनॉट से एविडेंस नहीं है. रिमेंबर दिस थिंग, यू कैनॉट से इट्स जीरो. देयर इज एविडेंस बट द एविडेंस इज very low quality. 4 is a high quality. You can therefore rate it down by 3, and in one domain, until otherwise proved, you can rate it down by, अगर एक से ज्यादा में प्रॉब्लम हो रही है एनी हाउ वेरी लो क्वालिटी तो हो जाएगा, बट टू मेंटेन द ट्रांसपेरेंसी यू विल हैव टू राइट दैट दीज डोमेन्स आल्सो हैड प्रॉब्लम. अब हर के लिए तो आप उसके बियॉन्ड नहीं जा सकते, बट यू नीड टू राइट दिस थिंग. So can we step up or rate up the evidence? This is beyond the scope of the lecture, but just for the sake of bringing it in, when you are looking at grade, can we step up the evidence? Yes. How? Very good. And just to give you a flavor of this thing, there are a few conditions when you can step up the evidence. So this is another guideline which gives you about the upgrading criteria for the non-randomized studies. If it is so robust, you can do this thing. But register this and do not fall into this thing. This is just for the sake of reference so that you know that it is there. But remember those 5 domains that are important. These 3 domains are for the non-randomized trials. So as I said, the quality of evidence and definitions is high quality, moderate quality, low quality, and very low quality. Last column of the summary of findings table. The words are derived from this table. Further research is very unlikely to change our confidence in the estimate of effect. Now, if you ask a policymaker or if you ask a funder, I want to do this thing, who would tell you, yeah, already the evidence is very high. Why do you want to invest into this thing? Invest into something which is required. Ask a policymaker, he would say, I am going ahead, formulate a guideline. Why I spend more time onto this thing? You have more diseases, more disorders where you should be investing your energy. So this is high certainty of evidence. Moderate quality is that further research is likely, may probably change the estimate. Similarly, for low quality, the likelihood that it might change in future is increasing. Very low quality is just like we know nothing. Just understand, उसको आगे फिर possible और उसमें quantify नहीं करना. Very low quality is like I do not know anything. and need further studies in terms of randomized, non-randomized, whatever that could answer your question should be taken. Now, touching upon to which we have already done to a considerable extent, we have done the bias. We know that it is a systematic error. Biases can lead to an underestimation, importantly, or the overestimation of effect. We saw the rules about the p-value. They may vary in magnitude. We've covered all this thing. We've covered that it looks at the internal validity of these studies. Okay. There was a bias we had discussed on that day that looks at the external validity. What was that? Huh? Just one bias I had told that looks at the external validity. Sampling bias. So when you have a sampling bias and the sample is not representative of the population, that is the actual bias that looks at the external validity. Otherwise, until otherwise proved, whatever things you are looking at, look at the internal validity. The ROB2 tool has been introduced to you. We have looked at the controlling confounding variables. So how do we assess? We have gone through this thing. This is the traffic light diagram that was shown to you that moves from the random sequence generation to the selective reporting part. This is how you say that there is a low risk of bias. You know, there are some concerns or there is high risk of bias. Earlier, the summary, if you're looking at the earlier papers, you might find the summary in the form of percentage also. 0 to 25%, 25 to 50, 50 to 75, and 100%. Again, defining low, unclear, or high risk of bias. Coming on to the paper, now I'll shift gears between the papers and my presentation. This is how you rated when Dr. Neeraj had taken the workshop. If you look at the first part, randomization process unclear, deviations from intended interventions unclear, selection of the reported results. I hope that you might have gone back and looked at the papers. If not, please do so that you can do this thing. I could hear comments कि इसके लिए क्या पेपर पढ़ना पड़ेगा, पेपर पढ़ना पड़ेगा. Remember this thing. ठीक है. आप पेपर नहीं पढ़ेंगे तो आपको समझ में नहीं आएगा. Please, this is as simple as it gets. We know that this was a study, was a single blind study. Okay. First thing, we made a note of it. Then making your task easy, but just you should be aware of the things. And we said it's about the ratio 1:1 ratio by block randomization method. Just go ahead. Now, here are few things that you should be aware of. Physicians and clinicians knew about the medicine and intervention groups. So we had discussed if the outcome parameter is not there, then the bias in terms of the observer can creep in. Okay. So this is a single blind, so one kind of bias can come in. Important is due to emergency nature of the trial, placebo of methylprednisolone were not present. The good part about the paper is that they listed everything. They did not leave things for you to, expect whether it was done or not, leave anything to chance. They wrote everything. This is also the reason why it was not rated for downgraded for seriousness. There is a serious level of, serious bias. You go down, and we saw that they have gone ahead with the expectation maximization algorithm. Expectation maximization algorithm is a part of ITT, that is intention to treat analysis. And this was the last thing, they did not receive the allocated intervention. So even though allocation concealment was done, there was a part, there were people where this was not done. So coming back to our ROB diagram, we can see why this bias, this risk of bias diagram, there is unclear risk of bias. So since the study by Munch did not have any problem, I'll just walk you through to the second paper by Geronimo, with methylprednisolone as adjunctive therapy for patients. Here there were, few but important tissues. This was how they allocated their intervention. This was the part where they used a modified intention to treat. I hope it's clear now. They used a modified intention to treat, then the intention to treat analysis, excluding only patients who had withdrawn informed consent, was also performed. So what have they done? एक तो एक सेपरेट टाइप का एनालिसिस किया और सेपरेट टाइप के एनालिसिस में भी दो एनालिसिस किए. Okay, it was not limited to just one thing. This is one red flag. This is very, very important. Whenever you are looking at the studies, that is the primary research, always see the algorithm of the study. In this algorithm of the study, what you can see, this is the protocol deviation. So protocol deviation, previous corticosteroid use, they said कि जिसने corticosteroid ना लिया उसको include करेंगे. So there was a flaw in the very enrollment of the patients. और include कर चुके हैं ये patients को और तब इनको मिला. Another thing was follow up में जब आए तो पड़ा कि फिर corticosteroids ले लिया था. This was a protocol deviation number 2. So until unless you're going through the paper, you might not find things which are here. I'll go back to my presentation. This was the reason that they deviated from the intended intervention and they had the selection of the reported outcome. तो जो बाहर निकल गया था उसको तो इंटेंशन टू ट्रीट से किया और बाकी को मॉडिफाइड इंटेंशन टू ट्रीट से किया. So that was the reason of labeling it as unclear. This we have touched nicely. And so in this ROB assessment, what we could see that in the Adalati FAD, we had three: unclear, Geronimo, Munch, none. So the domains we have listed, number of domains and the proportion that has been there. And that is when this is what the authors concluded, that we downgraded the evidence one level for serious risk of bias. Selection, serious risk of bias क्यों? क्योंकि एक से ज्यादा डोमेन में एक से ज्यादा स्टडीज के अंदर कंसर्न आ रहा था. If you see the last slide, you're looking at the domains affected and number of domains. So this was downgraded and there was missing information about the allocation concealment. Now coming on to the second part, that is inconsistency. If you look at the inconsistency, how do you define inconsistency or heterogeneity? Heterogeneity is variation. Yeah, keep it simple. There is variation. All things are not equal. Apples, pears, oranges, all the things are mixed. It's about heterogeneity. Any kind of variability which is there among studies, in the studies that you have pooled for your systematic review is known as heterogeneity. There are three types of heterogeneity. Whatever we are talking about today is more about the statistical heterogeneity. Most of the things you analyze when you are going through the paper, that is about clinical heterogeneity, methodological heterogeneity, and the statistical heterogeneity. When you're talking of clinical heterogeneity, we took an example of whether this is clinically important or not. If a drug reduces the blood sugar by say not more than 5, you may have a p-value that is significant, but that might not be clinically important. This has led to the concept of MID. At many places, you might find a MCID. So that is minimally important difference. It was initially known as minimally clinical important difference, but they have now kept it just as MID, minimally important difference. हर किसी के लिए अलग हो सकता है. लैब वालों के लिए मिनिमली इम्पोर्टेंट डिफरेंस हो सकता है कि अगर एक किट दूसरी किट के मुकाबले इतना डिफरेंस अगर डिटेक्ट करती है तो मेरे लिए वो इम्पोर्टेंट। तो क्योंकि ये लैब पैरामीटर्स में भी अप्लाई करता है, बिकॉज दैट माइट बी difference important for their group. So MID is a better term rather than a MCID. So how do we assess? This was taken up by Sir earlier also. We look at the statistical measure, which may be in the form of an I square or a large chi-square or tau, overlap of confidence intervals and similarity of point estimates. We'll go through it one by one. Now, if we look at the bottom couple of lines, in the case of a single study for an outcome, say that there is none rather than not applicable. अब आपके पास एक ही स्टडी है, तो वो दूसरी स्टडीज के कंपैरिजन में कैसी है, क्या लिखोगे? आप करोगे जब सब ग्रुप एनालिसिस, कई बार होगा कि आपको एक ही स्टडी मिली, दूसरी स्टडी मिली नहीं, तो एक तो ये हुआ कि मेटा एनालिसिस नहीं परफॉर्म कर सकते, बट एक ही स्टडी अगर आपको मिलती है तब क्या करोगे? तो यू विल राइट दैट देयर इज नन, दैट इज हेटेरोजेनिटी इज नन, रादर देन सेइंग नॉट एप्लीकेबल। ऐसा नहीं होगा कि एप्लीकेबल नहीं, कुछ तो हेटेरोजेनिटी उसके अंदर भी होगी, ठीक है, लेकिन नन व्हेन कंपेयर्ड टू, सिंस देयर इज नथिंग सो इट्स नन, दिस सिमिलर टू जब हमने 4 से 1 पे आए, 1 को भी अगर हटा देंगे दैट डज नॉट मीन देयर इज नो एविडेंस, देयर इज एविडेंस, इसलिए एटलीस्ट एक डायरेक्ट सम एस्टिमेट जरूर रहेगा। So how do we assess? We rate down for inconsistency when the point estimates vary widely. The confidence intervals do not show overlap. The statistical results, I'll take this in the next slide, that what is the permissible amount of heterogeneity, which is defined in the form of an I square. So a rough guide which is given by Cochrane is up to 50% on an average, you can kind of accept. Beyond that, if it is more than 50 to 90, it may show statistical heterogeneity. And in general, if it is more than 70 or 75%, then there is substantial or considerable heterogeneity. Why I say substantial as well as considerable? Because you can see that these two levels are overlapping. So depending upon it falls best into which type, you can write either substantial or write considerable heterogeneity. Now coming back to the paper that was discussed, anyone wants to analyze this forest plot? Yesterday you could generate the forest plot, I suppose. No confusions. And you generated that on the desktop version or also on the web? Desktop version. Okay. Here you can see these are the events, the total numbers, corticosteroid plus standard care, the amount of weight and risk ratio. If you were not shown this thing, you can define whether this was a fixed effect model or a random effect model. हाँ, अगर आपके पास अगर आपके पास रैंडम ये दोनों नहीं भी होते, आप देख के बता सकते थे ये फिक्स्ड इफेक्ट मॉडल है या रैंडम इफेक्ट मॉडल है। हम्म? कुछ कुछ चीजें देख के बता सकते थे। अगर आप जब स्टडी के नंबर्स देखोगे तो आप देख सकते हो कि वेट डिस्ट्रीब्यूटेड है या नहीं है। वेट डिस्ट्रीब्यूशन कब होगा? जब आप रैंडम इफेक्ट्स मॉडल में जाएंगे। नंबर वन। नंबर टू, when you are looking at these parameters, you are seeing a tau square. Tau square is not reported with a fixed effects model. ठीक है, अगर वो नहीं होता या अगर आपको एक इसका प्रिंट आउट मिलता जिसका उधर का पेज कटा हुआ है, ठीक है, सो यू कैन काइंड ऑफ डू फ्यू थिंग्स टू सी वेदर इट वाज देयर, इट वाज रिपोर्टेड और नॉट। So we have this thing. You have a chi-square which is on the higher side. The p-value is very low, and the I-square is 79%. Does I-square change with a random or effect model? आपको प्रॉब्लम आ रही थी कि हम मॉडल चेंज करके देखें, तो हिट्रोजेनिटी को क्या होता है जब आप मॉडल चेंज करते हो? हिट्रोजेनिटी कम हो जाती है। अदर एक्सप्लेनेशन? हाँ, जैसे डिफाइन करने के लिए देयर आर टू स्कूल्स ऑफ थॉट इफ यू आर लुकिंग एट कि हेटेरोजेनिटी हम मानते हैं किस तरीके से सो आई सेड we are looking at three things है ना clinical methodological and statistical heterogeneity this is statistical heterogeneity there is a very large school of thought which is looking at contextualized approach वो ये कहता है कि जब आप सैंपल ले रहे हो अगर वो सैंपल वेरिड पॉपुलेशन से है वेरिड जियोग्राफिकल रीजन से है तो वो हिट्रोजनस होगा ही तो रैंडम इफेक्ट्स मॉडल लेते हैं but the important thing to consider is statistical heterogeneity does not vary between the models important take home message तो वो रैंडम हो आई शो यू क्योंकि ये जो आपका पेपर है ये आपके लिए हमने जनरेट किया अलग से ग्राफ भी जो आपका पेपर है इसमें इन्होंने रैंडम इफेक्ट्स दिए हैं लेकिन फिक्स्ड इफेक्ट नहीं दिए यू जनरेट द ग्राफ फॉर द फिक्स्ड इफेक्ट आल्सो just to make the things clear. Whatever risk of bias we had generated, it can be seen, and this is present on page number 173 of the PDF that is provided. Now, this is the thing. Just look at the heterogeneity I square 79%, 79%. ये नीचे वाला जो ग्राफ है फिक्स्ड इफेक्ट का ये आपके पेपर में नहीं है बट जस्ट टू प्रूव आवर पॉइंट just to bring things in context we have generated this thing for you. So the p value is 0.009. The chi-square value is 9.35. Tau is not there. Why? Because this is a fixed effect model. What has happened is look at the estimate. Right. It's broad. Look at the estimate. Okay. अब जो सबसे ज्यादा वेट आपको मिल रहा था इकोनॉमिक स्टडी से मिल रहा फिक्स्ड इफेक्ट आपने क्या किया इसका जो वेट था वो उठा के रैंडम इफेक्ट्स में डाल दिया तो जो पॉइंट एस्टिमेट है ये छोटा हो गया और ये दोनों पॉइंट एस्टिमेट्स बड़े हो गए मेक सेंस जिसका सबसे कम वेट था उसको सबसे ज्यादा फायदा होगा तो जो 3% कॉन्ट्रीब्यूट कर रहा था वो 10 टाइम्स हो गया 30.6 जो 13.5 था डबल टू 26 पॉइंट तो दिस इज व्हाट इज ऑल्सो कंसिडर्ड एज अ रॉबिनहुड फिनोमेना राजा से अमीरों से खींच के गरीबों में बांट दिया दिस इज लाइक दिस all those weights which were not distributed initially and might have affected the actual or the common estimate अब common estimate हमारा अभी भी significant नहीं है so this proves कि अगर आपको कोई confusion है आप दोनों चीजें report कर सकते हो and you can leave this to the end user to understand that I have given you the facts use them as you want yeah direction के लिए matter करती है ना I'll show you in the other part of the graph also suppose this was the study, the last study by Munch. This was the study which was taking the direction to the opposite side. Okay. If the study is not there, what will happen? And this probably was the study with the largest weight, not the study by Geronimo. So the direction of the effect will change. If you are not performing both the models, you will never know that was the effect changing just because of one single study because it had a lot of weight बाहर की बहुत सारी ऐसी स्टडीज हैं जब आप लार्जर मेटा एनालिसिस करोगे तो जो डायरेक्शन ऑफ इफेक्ट है आप देख रहे थे कि फेवर्स इंटरवेंशन और जो इफेक्ट है वो चला गया फेवर्स कंट्रोल्स ओके दैट इज द रीजन नंबर टू इज रैंडम क्यों इंपॉर्टेंट होता है फिक्स्ड के हिसाब से आपको बिटवीन द स्टडी वेरिएबिलिटी नहीं पता चलती फिक्स्ड इफेक्ट में कि वो जो स्टडीज हैं ये जो टाउ हम पैरामीटर यूज कर रहे हैं इसमें आपको ये कभी पता ही नहीं चलेगा कि जो बिटवीन दी स्टडी थी उसमें वेरिएबिलिटी कितनी दीज आर टू इंपॉर्टेंट रीजंस आई शो यू इन द डेमोन्स्ट्रेशन इफ यू वांट कि उसको जब आप हटाते हो तो कैसा फर्क पड़ता है और अगर फर्क नहीं पड़ेगा दिस इज योर सेंसिटिविटी एनालिसिस ठीक है सेंसिटिविटी एनालिसिस में ही हम मॉडलिंग करते हैं आई टेक दिस अप इन माय सब्सिक्वेंट स्लाइड्स So, as I said, heterogeneity does not change, the parameters do not change. अभी डॉक्टर साहब ने कहा कि फायदा क्या है? फायदा दो चीजों में है, ई वैल्यू चेंज हो गई, एस्टिमेट चेंज हो गया, ठीक है? Z is 0.52, Z is 0.74, ठीक है? यहाँ क्या है? 0.74 रिस्क रेशियो है, क्या आ गया? 0.92। 0.92 आने का क्या मतलब हुआ? जीरोनोमो का सबसे बड़ा सैंपल साइज था, brought all the estimates towards a relative risk 1। relative risk कितना है? 0.92। इसमें क्या है? 0.74। जैसे ही वेट डिस्ट्रीब्यूट हुआ तो आपका जो क्यूमुलेटिव एस्टिमेट था, जो आपका डायमंड था, वो थोड़ा सा शिफ्ट हो गया था। दिस शिफ्टिंग इज नॉट एविडेंट until unless you do the modeling। तो जो चीज चेंज हो रही है आपकी मॉडल में, वो एस्टिमेट चेंज हो रहा है, बाकी कोई पैरामीटर नहीं चेंज हो रहा। रैंडम इफेक्ट्स में आपको टाउ अलग से मिल रहा है, विच इज अ कोरिलेट ऑफ टाई स्क्वायर। व्हाट डिड द ऑथर्स डू? दे डाउनग्रेडेड इट फॉर वन लेवल ऑफ सीरियस इनकंसिस्टेंसी, क्योंकि उसमें आपको क्या प्रॉब्लम आ रही है, जो हमने भी उसके साथ देखा था, हिट्रोजेनिटी वॉज वेरी हाई, जो डायरेक्शन ऑफ इफेक्ट्स हैं वो भी चेंज कर रहे थे। व्हेन वी लुक एट द अदर थिंग्स, इसी डिस्कशन में एक्चुअली आई हैव आल्सो कवर्ड द सेंसिटिविटी एनालिसिस आल्सो। द रिस्क ऑफ बायस असेसमेंट वी कैन डू, reprint वर्सेस जर्नल पब्लिकेशन वी कैन डू। reprint वर्सेस जर्नल पब्लिकेशन में क्या डिफरेंस हमको मिल सकता है? प्लेटफॉर्म ट्रायल्स वर्सेस नो प्लेटफॉर्म ट्रायल्स। एनीवन? व्हाट इज अ प्लेटफॉर्म ट्रायल? कोविड ने हमको बहुत प्लेटफॉर्म बारे में बताया। सो व्हाट इज अ प्लेटफॉर्म ट्रायल? प्लेटफॉर्म ट्रायल इज अ ऑनगोइंग ट्रायल। एक नया ड्रग आया, आपका पूल है पेशेंट्स का, उसी स्टडी में आपने उसको इंक्लूड कर लिया, स्टडी खत्म हो गई, पेशेंट चला गया, दूसरा पेशेंट आया, गॉट इंक्लूडेड ऑन थ्रू, लाइक एन ऑनगोइंग ट्रायल। तो एक प्लेटफॉर्म पे गाड़ी आती है, चली जाती है, प्लेटफॉर्म कहीं नहीं जाता, ठीक है? सो पार्टिसिपेंट्स आर कमिंग इन, पार्टिसिपेंट्स आर गोइंग। This is what is a platform trial, to keep it simple. So when you are having this thing, when a lot of variability is involved, when there is an urgency that you cannot devise a trial per se, everything takes time. So what you can do is एक regular feature पे अगर आप एक regular उस पे करते हो, basis पे चीजों को अगर patients का enrollment रखते हो, then you will have more answers in less time. Then with this we have discussed a fixed effect model and a random effects model. When there is heterogeneity, what should we do? Hmm? Which? Yes. तो हमारे पास चार चॉइस हैं, या तो इग्नोर करते हैं, या हमें कोई मतलब नहीं है, हमने देख लिया, बट वी डू नॉट वांट टू डू एनीथिंग। द सेकंड थिंग इज वी कैन लुक एट द डेटा, whether everything was filled correctly, whether everything falls in place or not, we can encompass it। यानी उसी डेटा को हम सही तरीके से कैसे यूज कर सकते हैं, एंड देन वी कैन एक्सप्लोर। इनके चार पार्ट्स होता है, we definitely cannot ignore it, otherwise this workshop was meaningless। we can check the data, इसीलिए तीन ऑथर और डुप्लीकेट में सारा, ठीक है? एक आदमी ने गलती करी, दूसरा आदमी जब डेटा एक्सट्रैक्ट कर रहा होगा उसको पकड़ लेता है, इसीलिए बोलते हैं मिनिमम 3 ऑथर्स होने चाहिए। डेटा एक्सट्रैक्शन जो होता है, स्क्रीनिंग होती है, मिनिमम 2 ऑथर्स करें, इन डुप्लीकेट करें, तो यू विल ट्राई टू कवर मोस्ट ऑफ द थिंग्स। क्रॉस ओवर ट्रायल है, यस मैम, तब तो हिट्रोजेनिटी हुई नहीं ना। हिट्रोजेनिटी तो हमने भी कहा कि जब मिनिमम 50% से ऊपर थी, या कंसिडरेबल रेंज के अंदर जा रही थी, सब्सटैंशियल या कंसिडरेबल रेंज, तब ऑफ कोर्स तो आप करोगे ही। कि जैसे अगर एनीथिंग वेयर द हिट्रोजेनिटी इज मोर देन 50%, एंड डेफिनेटली व्हेन इट फॉल्स इनटू द सब्सटैंशियल और अ कंसिडरेबल पार्ट, किसी भी जगह पे अगर 75 से ऊपर होती है, 72 75 यूजुअली लोग लिख लेते हैं, then you have to explore it कि heterogeneity इतनी हो क्यों रही है. Then encompass it. एक हमने already देखा random effects model. जब हम explore करेंगे, we can go into the subgroup analysis, funnel plots, अगर studies ज़्यादा हो या meta regression. This is how you try and see when there is heterogeneity, how you can handle it. With one, most of the points are covered. I'll take you through now. Just concentrate on the following graphs. We'll move it a bit fast because most of the things they have been covered. So this is a fixed effect analysis. सारी studies जो हैं common estimate के साथ हैं. It is also the reason why you do not have a how. Coming on to the random effects, हर study का अपना अलग estimate है. Therefore, dispersion ज़्यादा है. So when you are looking at the random effects model, जो आपको common effect आता है, that is more out, and the fixed effect which is narrower. Again, as a comparison, ऊपर random effect model, I do not want to even see it because I know that ऊपर वाला random है, नीचे वाला fixed effect है, common estimate बड़ा है, नीचे छोटा है. When you're looking at inconsistency, this is where a lot of confusion lies. What is the difference between a subgroup and a heterogeneity? Non-heterogeneity seeking parameter, that is sensitivity analysis. So sensitivity analysis is a parameter looking at the robustness of results, and subgroup is something which you plan ahead of time. A priori analysis looks more towards the heterogeneity, and a priori analysis looks at the overall. When there is an overall randomization, क्योंकि जितने भी आपके ग्रुप्स होंगे वो out of the derived population होती है, so they are balanced more likely. And when you are looking at the sensitivity analysis, ये जो randomization होता है might be different. Suppose आपने क्या किया कि high risk of bias वाली studies हटा के देखा क्या जो आपका pooled estimate है different है, randomization उसके अंदर आपका जो overall population का होगा distort हो जाएगा, which is not so with the group analysis. So we've covered two domains of bias and inconsistency. Now we'll move on to indirectness. Now things in indirectness are easy. Something which is not following your PICO indirect है, यानी कि एक exact population दूसरी exact population के साथ नहीं है. एक में जो मीन था 40 years था, दूसरे में मीन था 60 years. पॉपुलेशन सेम नहीं है, इंटरवेंशन डिफरेंट था, कंपैरेटर्स डिफरेंट थे, आउटकम सेम नहीं थे या कुछ वेरिएबिलिटी थी. एवरीथिंग कम्स अंडर indirect. So this is important when you are looking at the important outcomes. So population and intervention you have seen. You have seen the comparators. What we are left with the outcomes. Outcomes कितने direct हैं ये define करना बहुत जरूरी है. Suppose you give insulin to a patient and then measure the potassium. Will it make sense? And you tell them कि जब आप शुगर देते हो, शुगर का यूटिलाइजेशन होता है, उससे पोटेशियम लेवल्स वेरी करते हैं. क्या है? मल्टीपल उसमें स्टेप्स इन्वॉल्व हैं, बट दिस डज नॉट गिव यू अ डायरेक्ट इंसाइट इनटू टू व्हाट एक्सटेंट इंसुलिन वाज हेल्पफुल. ठीक है, आपने एक पेशेंट हाइपरटेंसिव है, उसको दवाई दी और उससे पूछा आप कैसा लग रहा है वो आपको, वेरी सब्जेक्टिव. आप उसको अगर चीनी की गोली भी दे देते ना तो उससे भी प्लेसिबो इफेक्ट आया था, हाँ डॉक्टर साहब अब थोड़ा सा अच्छा लग रहा है. ठीक है, the blood pressure actually fall. So the outcome should be direct, should be measurable. It should be related to the intervention that you are using. There are a lot of surrogate outcomes. Sir had introduced you to a term which is known as PROM. PROM is patient reported outcome measures. So now a lot of things जैसे quality of life कैसी है, अब आप क्या आपको behavioral changes आए उसके साथ कैसा आपको लग रहा है. So now a lot of research is going into PROMs. So you may, for the diabetes, you may have in terms of the patient, the diabetic symptoms, hospital admission, surrogate outcomes are blood sugar, HbA1c. Depending upon what you want to measure, आप ये देखना चाहते हैं कि अगर डायबिटीज के पेशेंट को मैं इंसुलिन पे मेंटेन करता हूँ, what is the likelihood that the patient will have diabetic nephropathy or not? और डेली ब्लड शुगर्स का कोई फायदा नहीं है, isn't it? So it depends upon what you want to achieve. इसलिए your brain open, do not restrict yourself in understanding कि इसका तो यही होगा. So for the common things we have given this as a parameter. अगर जैसे hypertension है, if the blood pressure you're measuring is normal, patient still has a stroke. You will try to explore it. कैसा क्यों हो रहा है? हो सकता है जेनेटिक प्रीडिस्पोजिशन हो सकता है बीच में दवाई मिस कर दी हो, दवाई जो वो ले रहा था सही डोज के अंदर नहीं ले रहा था, या जो ब्लड प्रेशर मेजरमेंट करने का जो इंस्ट्रूमेंट था वेदर दैट वाज वर्किंग नॉर्मली और नॉट वर्किंग नॉर्मली. यू मे हैव अ मल्टीट्यूड ऑफ रीजंस व्हिच आर बियॉन्ड द ब्लड प्रेशर कंट्रोल. तो डिपेंडिंग अपॉन व्हाट यू वांट, पेशेंट के लिए क्या इंपॉर्टेंट है कि अगर आप ब्लड प्रेशर की उसकी दवाई दे रहे हैं, साहब मुझे हार्ट अटैक ना हो, मुझे लकवा ना लगे, isn't it? He's not concerned with R. For him, R science is a jargon. ठीक है, उसको तो ये पूछना है कि साहब मैं इसको लूंगा, मुझे अगले 10 साल में क्या स्ट्रोक हो जाएगा, मुझे 10 साल में क्या हार्ट अटैक हो जाएगा. सो दीज आर दी पेशेंट रिलेटेड आउटकम. So when we are looking at the parameters, suppose we have this question: efficacy of phosphate lowering drugs in patients with renal failure and hyperphosphatemia. So when we are looking at this thing, we have patient important outcomes जो कि पेशेंट के लिए जरूरी है. You have the indirect, आपने कॉर्नरी कैल्सिफिकेशन देखा, ब्रेन में कैल्सिफिकेशन देखा, बोन डेंसिटी, एक्सा स्कैन कराया. और वेरी इंडायरेक्ट क्या है, आप कैल्शियम और वो मेजर करते रहो. आपको पता है जिनको नॉर्मो कैल्सीमिया होता है उनको भी ऑस्टियोपेनिया ऑस्टियोपोरोसिस होता है. मोस्ट ऑफ द पीपल्स most people have this problem. So direct indirect outcomes and patient related outcomes should be segregated. So how do we assess them? So we assess them in terms of these domains. As I said, this is directly about the PICO. So whether they correlate with this thing, this is purely on the basis of your direct evaluation and assessment of the paper. We've seen population was hospitalized and unvaccinated patients. Intervention was corticosteroids plus standard care. The standard care was the comparator. Was the outcome directly assessed? The answer is yes in the systematic review that we are assessing, and the outcome was mortality up to 120 days. So when everything was direct, what did the authors do? They said nothing was done in terms of downgrading the evidence. So indirectness इस पेपर में नहीं थी. ठीक है, we downgraded it for inconsistency and risk of bias. अब लास्ट हमारे पास क्या बचता है? Imprecision. फिर हम publication bias पे आएंगे. This is the fourth domain that we are assessing. Most things have been discussed. So you can focus on what imprecision is and to what extent or how do we define this imprecision. This is one of those aspects of reading which has blurred boundaries. Okay. For a person, the confidence interval might be precise, for the other it might not be. So as I said, as I told you in the summary of findings table, that we want a relative measure of effect, also a absolute measure of effect. So here we are saying avoid reference to the number of studies as a reason for imprecision. Look at the total size, the total sample that you have. Everything either in the term of events or in the terms of sample size. स्टडीज बहुत सारी हैं आपके पास, एक आपने सिस्टमैटिक रिव्यू किया, हर स्टडी के अंदर 10-10 लोग थे, तो 10 स्टडीज हो गए, इसका मतलब ये नहीं कि वो प्रिसाइज हो जाए. सो द प्रिसीजन डिपेंड्स अपॉन द नंबर, either the number of events or the number of samples. Then avoid reporting the result as statistically or non-statistically significant result. That is the reason we said that what is the confidence that we have in the estimate. कि हमें उतना कितना उसको चाहिए. अगर आज के समय पे आपके पास वेदर रिपोर्ट आ जाए कि 40% चांस रेन के हैं, पी वैल्यू इज लेस देन 0.05, आधे से ज्यादा लोगों को समझ में नहीं आएगा. फॉर देम इट्स इम्पोर्टेंट कि चांस क्या है, मुद्दे की चीज हमको ये बता दी जाए. तो दैट इज द रीजन वी से दैट इसको लिखने के बजाय विच इज मीनिंगफुल, राइट दोस टर्म. This has already been covered in terms of If it is a relative risk, falling at 1 is not significant. Then if it is not significant, what you can do is we can write if the confidence excludes the risk and includes the risk. If it is including the risk, you downgrade. If it does not, you do not downgrade. OIS criteria will touch upon it. This is the optimal information size. कॉम्प्लेक्स टर्म लगता है इट्स ओनली अबाउट कि जो आपके पास इवेंट रेट है या सैंपल साइज है वो एडिक्वेट है आपके मेटा एनालिसिस के लिए या नहीं. तो दिस टर्म दैट डॉक्टर प्रताप यूज्ड ऑन दैट डे कि जब रिलेटिव रिस्क रिडक्शन होता है तो हमारे पास ऑन एन एवरेज इतने नंबर ऑफ इवेंट्स होने चाहिए. सो एज अ रूल ऑफ थंब, इफ यू हैव अराउंड 400 इवेंट्स इन ईच ग्रुप, आपने जब सिस्टमैटिक एनालिसिस सिस्टमैटिक रिव्यू किया और मेटा एनालाइज किया, तो अगर एक ग्रुप में आपके पास एटलीस्ट 400 इवेंट्स हैं, प्रिसाइजनेस आपको मिल जाएगी. दिस इज एज अ रूल ऑफ थंब. व्हाट इट इज कंसिडरिंग, अगेन कमिंग बैक टू सीआर. सीआर आपका पीछा नहीं छोड़ेगा, रिमेंबर दिस थिंग. So you should have your fundamentals in this. So even if it is at 0, दूसरे ग्रुप के अंदर कुछ भी नहीं आपको मिल रहा, but you are getting this size, these number of events, you will be fairly confident in the preciseness. So the magic number here is 400. In terms of the imprecision, sir had walked you through the कि आई बॉलिंग करते हैं, आप देखते हो कि ओवरलैप कर रहा है नहीं कर रहा on one side of the relative risk or odds ratio or not. Let's just see. If you have a forest plot that is generated like this, how will you say that this is important, not important? तो यहाँ से हमको क्या दो चीजें मिलेंगी, heterogeneity का पता चलेगा और imprecision का पता चलेगा, है ना? So we'll look at domain 2 and domain 4, that is inconsistency and imprecision. Any thoughts on this thing? कोई भी एक, हाँ? Why? That is consistency, it's about the precision. We are looking at minimal heterogeneity, understandable because आपको एक ही उसके अंदर मिल रहे हैं, they are in line and the confidence intervals are overlapping each other, और आपका favors intervention and favors control zero था, they are on one side. ठीक है, so they are favoring the intervention. So when they are favoring the intervention, they are on one side and they are overlapping. तो आपको दो चीजें पता चल गई कि important difference था और आपको heterogeneity significant नहीं थी, defined as a minimal heterogeneity. Yes. Mhm. In the funnel plot. Yeah. See, but that is like different. You do not, plug the parameters and get this forest plot in terms of the publication. It is covered as a part of publication bias. If in that publication bias you find that you are not having studies which are representative of what you are finding, you will rate it down. But this does not come as a part of the forest plot. अगर आपको एक्सप्लोर करना है, तो हमने एक्सप्लोर करने के अंदर जब हमने सेंसिटिविटी एनालिसिस का बताया था, तो आई हैव अराउंड 18 मोर मिनट्स. सो अगर मेरे को टाइम मिलता है तो मैं आपको प्लग इन करके दिखा दूंगा. आपने हाई रिस्क ऑफ बायस वाली स्टडीज हटा दी, या एक हमने क्या बोला था कि प्री प्रिंट है और एक पब्लिश्ड है, उनको हटा दिया. सो दिस अकर्स, आप उसको एट द क्लिक ऑफ बटन कर सकते हो. तो आपको उसी समय पे पता चल जाएगा कि आपका पूल्ड एस्टिमेट कहाँ जा रहा है। सो दैट इज द आंसर टू योर क्वेश्चन, बट इसमें पब्लिकेशन के बेसिस पे चीजें नहीं आती। इट्स यूज्ड टू ग्रेड इन टर्म्स ऑफ ग्रेडिंग द एविडेंस, दैट इज सर्टेनिटी ऑफ एविडेंस। व्हाट हैपेंस नाउ? कॉन्फिडेंस इंटरवल तो स्प्रेड हुआ ना, ये स्प्रेड है, स्प्रेड तो सेम है, कॉन्फिडेंस इंटरवल कैसे इंक्रीज हुआ? यस। अब दो स्टडी यहाँ पे, दो यहाँ पे है, ओवरलैप नहीं कर रहे हैं, हिट्रोजेनिटी तो है, बट इट इज मीनिंगफुल और नॉट? एक ऑन वन साइड ऑफ द लाइन है। हम इसको कैसे रेट करेंगे कि हिट्रोजेनिटी इज प्रेजेंट और नॉट? हिट्रोजेनिटी इज प्रेजेंट, नहीं ग्रेड नहीं कर रहे हैं हम, हमें पास नंबर्स नहीं है, हम कुछ भी नहीं बोल रहे हैं, आई बॉलिंग कर रहे हैं ना। दिस इज जस्ट आई बॉलिंग। तो हमको आई बॉलिंग में पता है कि दो स्टडीज एक साथ हैं, दो स्टडीज एक साथ हैं, बट दे आर ऑन वन साइड। तो दिस कम्स, brings us back to the concept of which he started, the direction। तो यही डायरेक्शन यहाँ हो जाता, ठीक है। मैग्नीट्यूड कितना भी हो, डायरेक्शन चेंज हो गया, इसका मतलब अगर दो स्टडी कुछ दिखा रही है, दो स्टडी कुछ दिखा रही है, यू विल से वी डू नॉट नो एनीथिंग, ठीक है। तो फिर हमको नहीं पता ना कि क्या हो रहा है, बट इसमें दे आर ऑन वन साइड, दे आर फेवरिंग द इंटरवेंशन, स्टिल फेवरिंग द इंटरवेंशन, सो वील रेट दैट देयर इज सब्सटैंशियल हिट्रोजेनिटी। सब्सटैंशियल कहने के लिए हमने क्यों यूज किया? क्योंकि कॉन्फिडेंस इंटरवल का कोई पार्ट ओवरलैप नहीं कर रहा इसमें। तो जो लोअर बाउंड और अपर बाउंड है, अपर दोनों स्टडीज का लोअर बाउंड, और जो लोअर स्टडीज का अपर बाउंड है, वो भी ओवरलैप नहीं कर रहा, सो इज सब्सटैंशियल हिट्रोजेनिटी, बट द डिफरेंस इज मैग्नीट्यूड इज फेवरिंग द इंटरवेंशन। अब हिट्रोजेनिटी तो नहीं है, चारों के कॉन्फिडेंस इंटरवल ओवरलैप कर रहे हैं, बट all these studies are showing that we do not have a significant effect which is favoring either the intervention or the minimal heterogeneity, but apparently हमको कोई information नहीं मिल रही। Now coming to the last, a very important forest plot, ठीक है। Heterogeneity है, very good, but the direction, hope this answers your question। So what has happened is the direction of effect, इसका डायरेक्शन फेवर कर रहा है इंटरवेंशन को, इसका फेवर कर रहा है कंट्रोल को। तो मीनिंगफुल इज अनसर्टेन, ठीक। इसमें तो हमको पता है कि जीरो पे है, कोई फायदा नहीं है, बट इफेक्ट दोनों मैग्नीट्यूड में भी शो कर रहे हैं, बट जो इम्पोर्टेंस है वो इक्विवोकल हो गई। इसको तो फायदा दिख रहा था, उसमें कंट्रोल को फेवर कर रही थी। So these are the things which are important. So when we are looking at imprecision, we might ask how imprecise. Here creeps in the importance of what you are doing. आप क्लिनिकली क्या देखना चाहते हो? आपके लिए जैसे हम ये कहें, हमारे लिए मार्जिन ऑफ इक्विवेलेंस एटलीस्ट इतनी होनी चाहिए। तो अगर किसी का कॉन्फिडेंस इंटरवल जा रहा है 0.99, तो करीब तो सिग्निफिकेंट रहेगा क्योंकि वन तक नहीं पहुंचा, बट ये क्या है, रिस्क डिफरेंस है, जीरो है। तो जीरो है तो अगर 9 तक भी जा रहा है, तो आपने कहा कि स्टैटिस्टिकली तो सिग्निफिकेंट होगा, बट क्लिनिकली मेरे लिए ये इंपॉर्टेंट नहीं। दिस इज द प्रिंसिपल बिहाइंड द एमआईडी जो हम अभी तक कह रहे थे, दिस इज द मिनिमल important difference। So on the basis of this, we can develop thresholds। Sorry। So this is the threshold जिसमें हमने कहा कि इसके लिए हम मिनिमल कंसिडर करेंगे टॉक्सिसिटी। दिस इज द थ्रेशोल्ड अगर क्रॉस करता है फॉर द साइड इफेक्ट्स, वी कैन डिफाइन दोज थ्रेशोल्ड्स। इसके बियॉन्ड हमारे लिए, दिस इज द इम्पोर्टेंस ऑफ हैविंग अ कंटेंट और अ स्पेशलिस्ट इन योर ग्रुप। आप एक स्टडी कर रहे हैं, as sir might have taken a lecture, reproductive health। अगर आपको ये लगता है कि एक दवाई देने से ओव्यूलेटरी साइकिल्स के हिसाब से नंबर ऑफ ओवा जो आपके पास आते हैं, आपने जो बताया कि हमारा ये कट ऑफ होना चाहिए, माइट नॉट बी क्लिनिकली इंपॉर्टेंट फॉर फर्टिलाइजेशन। फॉर ब्लड प्रेशर कितना ड्रॉप है, फॉर ब्लड शुगर कितना ड्रॉप है, डिफाइन योर ओन लेवल्स। इसलिए अगर आपके पास ये है और आपके पास 4 स्टडीज आई, so now does that make sense what we had already seen in the past forest plots? हाँ, अब हमने क्या किया कि ये तो लाइन स्टैटिस्टिकल नॉन सिग्निफिकेंस की है, हमारे हिसाब से दिस इज द लाइन विच आई वांट टू मेक, तो दिस इज माय एमआईडी। तो इस एमआईडी से ये स्टडी यहाँ पे है, ठीक, इसका एक विस्कर इससे ओवरलैप कर रहा है, एक पॉइंट नीचे गया, ये इधर कर रहा है, और इफ इट इज मूविंग टुवर्ड्स नॉन सिग्निफिकेंस तो दोनों पॉइंट नीचे गए। तो इट्स ओनली अबाउट स्टैटिस्टिकल सिग्निफिकेंस, तो यहाँ पे आप डाउन रेट नहीं करते। दिस वाज ऑन वन साइड, इजंट इट, वाज इंपॉर्टेंट, स्टैटिस्टिकली सिग्निफिकेंट, लेकिन यही अगर क्लिनिकली इंपॉर्टेंट थ्रेशोल्ड होता तो डाउन रेट करते थे, ठीक है। एंड इफ यू वांट टू सी हाउ इट इज रिटन, इट्स अबाउट definitely clinically effective, probably why the estimate is on this side, कॉन्फिडेंस इंटरवल वहां तक है, स्प्रेड वहां तक है, इसमें एस्टिमेट ही अंदर आ गया, दिस इज पॉसिबली डेफिनेट क्लिनिकली इफेक्टिव एंड दिस इज डेफिनेटली क्लिनिकली इनइफेक्टिव। So this is about the magnitude. Look at the direction, lowers versus the upper bound. So this is the lower bound, this is the upper bound. तो ओवर लोअर और अपर बाउंड इसका और इसका ये तो बिल्कुल नहीं टच कर रहा, तो हिट्रोजेनिटी भी अगर क्रीप करेगी, बट ये हमने हिट्रोजेनिटी पढ़ाने के लिए नहीं किया, जस्ट टू इम्प्रेस अपॉन व्हाट इज अ minimally important difference. So the study that we had looked at was looking at the all-cause mortality. For this, now see what are the number in terms of the event. 89 है, 97 है. What is the spread? You can see the overall spread. The pooled estimate is 0.74 and it is 0.23. There are few papers which say that if you are moving beyond 2.5 to 3 times the lower and the upper bound, there is no preciseness. तो हमारे पास कितनी चीजें हैं प्रिसाइसनेस देखने के लिए? हमने क्या बोला था कि हमारे पास इवेंट्स लगभग कितने होने चाहिए? 400। हमें डिफरेंस कितना मिल रहा है यहाँ पे? 26%, 0.74 है ना, तो 25% पे कितना था? 400 था। नंबर्स कितने? 89 है, 97। इम्प्रोसीजन आंसर, ठीक। हमारे पास स्प्रेड हमको दिख रहा है, वाइड स्प्रेड, दैट मीन्स कि इसका जो प्रिसीजन है कम है। वी आर लुकिंग एट द रिस्क रेशियोज, इफ द रिस्क रेशियोज 0.23 into 3 is 0.69 और अपर बाउंड क्या है? 2.25 से ज्यादा है। This also tells you it is imprecise. We can use all these things to define whether imprecision is there or not. This is the total sample. These are the number of events. This is the effect estimate. So what the authors did was right. One level for serious imprecision because of wide confidence interval and low number of participants oblique events. Coming on to the last part, the publication bias. What is desired is we have to indicate the reason or methods used to detect the publication bias. So you may have an asymmetrical funnel plot. You may have small studies with positive results, suspected selective availability of data from published or unpublished studies. I'll walk you through because in the systematic review that we are analyzing, how many studies were there? 3. Usually for the generation of funnel plot, how many studies do you require? A good or a reasonable cutoff is 10. So what it is actually, how many of you have seen a funnel plot? X और Y एक्सेस पे क्या क्या होता है? थोड़ा सा जोर से बोलिए। हाँ, रिलेटिव रिस्क किस पे होता है? जो भी एस्टिमेट ऑफ इंटरेस्ट है दैट विल बी ऑन द एक्स एक्सिस, और जो उसका स्टैंडर्ड एरर है, स्टैंडर्ड एरर डिपेंडिंग अपॉन हाउ यू आर कैलकुलेटिंग इट, यू कैन यूज द लॉग्स, यू कैन यूज इट डायरेक्टली। स्टैंडर्ड एरर किस चीज पे डिपेंड करता है? द नंबर ऑफ द ओवरऑल सैंपल साइज। जितना सैंपल साइज बड़ा होगा तो कम होगा। So I'll come back to this slide and show you. This is the reverse configuration, which is important. So on the top, you do not have the largest number. You have the smallest number goes down, and this is how the log scale. You can have changes with respect to the numbers. The important thing to understand is usually the studies on the top have the largest numbers, and depending upon the log or the odds, you will have the representation on the x-axis. I'll come back. It's a scatter plot of the effect estimates from the individual studies against some measure of each study's size or precision. Standard error is usually used. You have a reverse scale, so larger, most powerful studies, usually those which have the largest sample size, appear towards the top, smaller one, they scatter more widely towards the bottom. In order to have the representation of all kinds of studies, it should ideally be filled up. In the absence of bias and between study heterogeneity, the scatter will be due to sampling variation alone. This is like what has been said. So you may have asymmetrical filling that is occurring onto one side. You may have the change either on one side or the opposite side. You can change, don't worry about the correct estimates, you can change the size and the color. When you have the asymmetrical funnel plot, you look at the reporting biases in terms of the publication bias or selective outcome or analysis reporting. May tell you about the methodological quality, how they are getting published or not getting published. True heterogeneity, we said, Sir had also alluded to about, you may remove the studies at higher risk of bias and see. कि आपके पास जो बची हुई studies हैं, how are they contributing to the pooled estimate? And this may even be artifactual or by chance. This funnel plot you will not find in this paper because the authors, when you'll go through the paper, you'll see that the authors said that we'll plot this if we have a minimum of 10 studies. There were only 3 studies we generated just for the sake of generating it to show you. जो बीच वाली जो स्टडी है वो प्रोबेबली कौन सी होगी? जिरोनोमो की स्टडी। जो लेफ्ट साइड वाली स्टडी है कौन सी होगी? कौन? दिस साइड, मंच की, इडालिटी पार्ट की, the opposite side of. So they did not generate it, they did not find any significant problem with this thing. To conclude, the SOF table provides a snapshot of magnitude, amount, and certainty of evidence, which is defined by grade. Which are the 5 domains of grade? Number 1 is risk of bias. Number 2 is inconsistency. Number 3 is indirectness. Number 4 is imprecision. And number 5 is publication. Excellent. Sir, we can close the session. They have learned. Grade framework principally utilizes 5 parameters, which is risk of bias, inconsistency, indirectness, imprecision, and publication bias. I have 4 minutes before we leave. I'll just show you. There was a question on this thing. If I can. Paper that you have, this is what we were seeing. This is the mortality. This is what you have in the paper. Okay. So we want to investigate sensitivity and got it. So this is the random effects model. You have all the parameters that are listed here. This is the pooled estimate. You have the events. I hope you can appreciate how things are here. We had not shown the fixed effect model. This is at the click, you can see the fixed effect model. Tau disappears, the weight changes. Now, what the thing is here, there was another question about the risk of bias, high flow and low flow, isn't it? High flow oxygen in the dialeptified group. There was a question. We'll explore it in 2 minutes. You thought that probably the study by Munch is dragging the estimate onto the opposite side. कुछ नहीं करना, just remove it. कुछ फर्क पड़ा, वो studies रह गई, है ना? You brought it back, इसको remove किया और wider हो गया. तो आपका क्या pooled estimate change हो रहा है? No, qualified किया. कुछ push and pull है, but the pooled estimate is not changing. There is no fun in removing or adding these studies. Let us go back. These studies. I'll edit the analysis. I'll show you. So just for the sake of the question on that day, put in this parameter on the basis of oxygen usage. You can appreciate this oxygen usage. I'll put this filter. This is a kind of what? Subgroup analysis. Okay. This is the SOC. Right. So if you wanted to evaluate whether there was a difference between a high flow and a low flow oxygen, तो इसका कोई contribution उसके साथ में आ ही नहीं रहा in terms of that because it is not contributing anything. So this is how you can do this thing at the click of a button, the way you want, but the concept should be clear because this is a software. अब कहीं भी कुछ भी क्लिक करेंगे तो कुछ देगा आपको, है ना? But it is important that you put your brains into it, how we have to assimilate that evidence. I suppose so sensitivity analysis is not a problem. Okay? We close this session and I am not killing. Thank you so much.
And, I'd like to invite the chairpersons for the next session, Dr. Raju Khan, who is a principal scientist and professor at CSIR MP, and Dr. Shramana Mukhopadhyay, madam, who is an additional professor in pathology department at AIIMS Bhopal. I welcome you, sir, and I hand over the next session to you.
Good morning, everyone. So, in this session, we have the very popular talk, evidence-informed healthcare using the GRADE approach to inform health decision by Professor Eminent and Dr. Eminent Pratap Aryan from Clinical Epidemiology Unit, CMC Vellore, India. So, now I invite you to give your shutdown. Thank you very much.
Thank you. This is going to be fun because this will be a test of how attentive you were during this week because it's going to be a revision of what we did. So, we are going to see what are the steps involved in using reliable evidence to make a health decision, right? And this health decision can be at any stage, at your local clinical level, your department, or your state, or your university. And I must say that all this got a lot of impetus. You heard this morning from somebody from WHO, right, who's talking about all the guidelines they do and stuff and so on. That is a recent phenomenon because if you look at this slide, you see that in 2007, the Lancet, there was an article published by Henry Oxman, John Lavitz, and all. They're all Cochrane people. They started by saying WHO regulations dating back to 1951 emphasize the role of expert opinion in the development of guidelines, of recommendations. However, in 2003, they revised it, saying you need to use systematic reviews. And so they wanted to say how much of the evidence, or guidelines, and recommendations WHO gives is informed by evidence from systematic reviews. So they went and interviewed the department directors of WHO Switzerland and a sample of the recommendation committee reports, and they discussed a lot of other people also. And they finally concluded that systematic reviews and concise summaries of findings are rarely used for developing recommendations. Instead, processes usually rely heavily on experts in a particular specialty rather than representatives of those who will have to live with the recommendations or on experts who have any methodological idea. So that was a very damning report which came out in the Lancet about WHO's recommendations. So shortly after that, WHO decided we have to change. They tried a guy called Pang. He was asked to frame a reply apology to the world why WHO. They said, see, we didn't know about this and we had no idea how to do it, but we will do it. And they formed a guideline review committee, right? And one of the first things they did was came up with a definition of what is a guideline. That among all their documents, they know this is a guideline, this is not a guideline. Okay. Around that time, uh, I got involved with this process because Pete Pang was actually very antagonistic to Cochrane because Cochrane reviews are all saying doesn't work. So we had this big discussion, and he's come up with the idea of writing a co-paper so we can get WHO and Cochrane together, right? This is what he wrote. And I'm very impressed by this because what he's talking about is that every policy document needs an evidence footprint, which tells you what are we basing this recommendation on, right? And that is exactly what we've been discussing over the past week. And over the past week, we tried to get a systematic review done on particular questions. We did a meta-analysis. We know the risk of bias in those studies. If you had read papers or at least read the review, you will know what was the population, what were the interventions, comparisons, and outcomes of each study, right? So that is what we need to today create a summary of findings table, which can then be handed over to a committee who wants to make the guideline. But you can't give them the systematic review, they won't read it. They have to prepare an evidence brief or policy brief, which summarizes everything. So, actually speaking, the summary of findings table to provide enough information for them to make up their mind whether it's worth changing your decision. For that, we're going to use this we call grade. Now, this is the website of the working group, right? This tells you all the work they do and links to all the methodology papers. And you can join them. They are looking for people to do partners in the grade process. And this website, I hope you all have registered, Grade Pro. You can go in and become a free registration. And what uh, Grade does is uses, so if you won't click in, this is what you'll get. What can you do with GDT? You can create evidence tables, you can create guidelines, and you can use it to disseminate data by creating policy briefs. There are lots of helpful tutorials and stuff for you to understand this process. Now, when you open it, you can open with the Cochrane Reviewer, automatically you get all the resources. Because Cochrane and Grade Pro, Redmine and Grade Pro sync together. But you can also do it yourself. You can open, say, my private workspace. Use anything that they have there, create a non-Cochrane. So I have been doing a lot of non-Cochrane reviews, other people, and this is good for creating summary of findings table. And you can import your RevMan file into Grade Pro, and this will be what you get. This is actually looking at the question of should oral misoprostol, how does it compare to vaginal misoprostol for labor induction in women at term with singleton pregnancies. This is the OG group. And the primary outcome, there was a Cochrane review, and there's a nice guideline. The answer to that is titrated oral misoprostol every 4 hours or 2 hours, which our nurses cannot do. We just don't have personnel to titrate every 2 hours. So we said we'll ask a different question. What is 4? We can do it 4 hours or 6 hours. So this is the question. And our primary outcome, critical outcome, is vaginal delivery within 24 hours. And we had 11 RCTs, many of them are from India, and they had 2,721 participants. That's the first line. The relative effect in that was, pooled effect was 0.82, confidence interval 0.7, 0.96. And then you have two columns saying without oral, that is vaginal misoprostol, and with. It gives you the absolute risk. 56% will have vaginal delivery if you use vaginal, and only you get 26.7% is a confidence interval. Give you this difference. And what we have, this program does, Redman has done all that. Look, get it into Grade Pro. Grade Pro will come. All these figures will come. Right? What we have to do is, how certain are we that is the true estimate? And that we can actually trust it and use it. That's what we are doing. Everything else the program does. You might have to uh, edit some of the columns there. So what we are going to do is summarizing the evidence from a systematic review. And for that, we need to know from systematic review what is the evidence. Do the pooled effect estimates and the confidence intervals for each critically important or critical outcome regarding efficacy, safety, functioning, whatever you think is critically important, indicates clinically appreciable advantages, not just statistically, clinically appreciable. As we discussed before, we need to know what is the minimum clinically important difference that we want. Lower limit of the confidence interval. We should say that is also meaningful. Patients. And we are looking at it in terms of the relative effects. How good is the intervention versus the comparator, as well as the absolute effects. How much benefit we get in the population that we are using the drug. It's the absolute risk difference. Depends on the baseline risk or the control group event rate. You get this point? We've been through it many times. Somebody asked me a question about CER, control group risk. You see the difference. You have a relative risk. That relative risk is saying for this outcome, this drug is better than that by so much. Right? Now you take that drug and you give it to a population which has a low risk of getting that outcome. They don't have a disease or it's not very severe there. So this is a very good drug. But the number of people who are going to benefit in the population is not much. And you'll have to treat many, many, many people to get one of them to show a benefit. Whereas if you use the same drug in a population where they are likely to have that alternate treatment, then it will make a big difference and you will need to treat very few people before you start seeing benefit. That's the difference. So you need to know both these. So when you're looking at the summary of finding stable, you see a relative risk, right? Then you saw the last time relative risk low and limit is only 0.9, right? But vaginal deliveries are pretty common. Then you find that the number of people who benefit, both the upper and lower extremity, the absolute benefit is very low. Then we also need to know how confident we are in that evidence. Is it likely to be a true estimate? Are these estimates precise? Upper and lower limits say that it will, you want to use it, and is it consistent across all the studies? We also want to know, if I use this drug, am I likely to see it? Right? If I use it. We also want to know, if somebody does another study on the same thing, so someone is asking, how many studies are needed to do a meta-analysis? For a meta-analysis, right? There are two ways of answering that. If you just want to do a meta-analysis for publication, you need at least two studies looking at the same thing. But if you want to know, can I really trust this result, then there's a different way. You need a sample size, optimal information size. You need more events and you need more people. Then you can say at one point, don't do any more studies. You won't get any result different from this. I'll show you what that means. Now that you will tell me what it means. But you're going to do this. So the thing is, grade is applied to outcomes. You select some outcomes, right? And for if you've got more than one comparison, you have a separate summary of findings table for every comparison. Okay, so you first define how many comparisons, then you choose the outcomes. And the outcomes you've selected that you will actually see. Yesterday we were having some discussion. Before we were having discussion of they only allow 7 outcomes, right? That is because grade recommends only 7 outcomes. So you can choose 25 outcomes, but before you do anything, you have to decide which are the ones that are likely to change clinical practice. Only those you will use. Okay. So you have to choose at least maximum of 7, and you have to present them with the relative estimates and absolute differences. And for each outcome, you grade the outcome. So the very first step is when you're writing your review, that's planning stage, you need to have a discussion, your team and potential users. What are the important outcomes for this comparison? And from that, you rate the outcomes. And if anything you rate as 4 out of 10, 10 is really important. Anything below that, you don't use. Don't use. That's only of academic interest. Right. And then, for example, I did this earlier. You're looking at viral pneumonia with high mortality. I think most people will agree that mortality, hospital admission, pneumonia are critical. And neurological complications are also important, right? But you're not really so important with some of the minor side effects which people can just make some decision. So you won't take that, right? Similarly, if you're using phosphate lowering drugs in people with renal failure and increased phosphate levels, you will take the important and critically important clinical outcomes. You won't take the less important outcomes, and you should not ideally take proxy indicators, surrogate outcomes. Now, the point is this: in most publications, you will find only surrogate outcomes, right? Or if you're using it diabetes, usually you'll find they're measuring blood glucose or HbA1c. If you're measuring hypertension, you'll find blood pressure readings. For dementia, cognitive function tests, osteoporosis, bone density. Like that, it goes on. The actual thing you're trying to prevent is not the blood pressure or the sugar. You're trying to prevent what the outcome, clinical outcome is. You're treating a diabetic, not to just bring his blood sugar down, but to prevent complications. You're treating hypertension, prevent a stroke or those other outcomes. That is what you should be measuring. That is what grade is encouraging you to do. In case you don't have any other outcome, you might be stuck with some kind of clinical or proxy indicator. So the process is like this. At the PICO stage, you choose your outcomes or important ones. You extract the data from that. You assess risk of bias and you do your meta-analysis. And then you create a summary of findings table where all you'll be doing is creating confidence in the evidence. High certainty, moderate certainty, low certainty, very low certainty. And there are criteria by which you will do that. And we'll go through that one by one. So first thing is you learn is can you trust the evidence? And you look for risk of bias in the meta-analysis to make sure that the studies contributing to the meta-analysis are free of the risk of bias ideally, or if there is some uncertainties, is it likely to make a difference to the result? Two steps here. Is there bias? If there is bias, is it likely to influence your outcome? If it influences your outcome, then you have some doubt about the result. Second is, can I apply this to my setting? So, from the included studies of the papers contributing to the meta-analysis, you need to know, have they studied the populations and the comparisons that I'm interested in, or the health setting similar to the one that I'm going to? You had this talk earlier on these issues. How do you decide indirectness? Third is, are the results consistent of all the trials? If not, can I explain the inconsistency? If you can explain it, you don't need to be less confident about the result because you know why these are different. Fourth is, are the results precise? Which means, are they creating confusion? The confidence intervals, are they creating confusion in your head about try or should I not use? At the upper limit and the lower bound of the confidence interval, you say, it doesn't matter, I'm still going to use because I'm going to get a clinically appreciable benefit when it is precise. Okay, that's one of the things to keep. And second thing is, you have enough data to ensure that this gives a precise result, or not a spurious false positive result. And finally, is the evidence complete? Do I think I have all the relevant trials, or only do I have access to easily accessible results? Usually they're accessible because they're positive results. Right? These are the 5 criteria on which we will do a grading. And because our CTs are supposed to be free of selection bias and other things, it starts as high certainty. But for any of these criteria, we can down our confidence in that result can come down by 1 level or 2 levels, depending on what the problem was. Any of these. If you at any time you bring down the confidence by 1 level, all evidence goes down from high to low. You downgrade further, you can go to low, and finally can reach very low. You can reach very low within the first 2 itself, but you still have to grade. Okay. Observational studies, because they potentially have selection bias, they start off as low certainty evidence, and they can be downgraded further if there are more bias, if they are badly done. But if you do not downgrade them, only if you do not downgrade them, then you can consider, can I have more confidence in these results? And for that, there are 3 criteria. I'll go through that later on how you can build your confidence in systematic review observational study. To even get a high certainty evidence from systematic review observational studies. Okay, and this will give you a final grade, high, moderate, low, or very low. And what that translates into is the way you're going to write your results, right? So if you have high certainty evidence, because you're very confident, because none of those factors had to downgrade on, I can be sure I don't have to do any research and I can use it in my practice. I'm likely to get similar results to what they got. So you will say, this will happen. With this drug, this will happen. That's your confidence. If by any chance, for any one criteria, you reduce your confidence, you will say moderate certainty, which means it probably will or it likely will. Introducing that element of doubt. Okay. If you go to low certainty evidence, you're saying it may. I'm not really sure. It may. And if it's very low certainty evidence, you say very uncertain. Like I don't know at all. Okay, so that's what we are trying to get here. And if you go to Pro website and go to resources, you find a lot of useful things you can use. In the book, there are a lot of papers on every aspect of these. All of these are published in the Journal of Clinical Epidemiology. Most of them are open access. And if you're going through an institution and they have a subscription to it, read all these papers. They're written by Gordon Guyatt and people who are part of this great handbook is also very, very helpful. Okay. So we had on the first day talked about this girl, Gauri Galapati from Sri Lanka, who asked the question, why is it that in India, Sri Lanka, and some other countries in the region, we are giving 5 days of primaquine following chloroquine, kill the hypnocytes and prevent relapses in Vivax malaria, when WHO recommends 14 days of primaquine, right? After giving chloroquine. That is what we had. And we had looked at this Cochrane review, and we had entered some data, at least one or two reports yesterday. And in that review, we found we are asked two questions. Did you give primaquine at all after chloroquine? Or the standard dose is for 15 days, right? Any other dose or duration compared to standard dose. So there are two major objectives. For the first objective, we found 6 trials. Two of them had compared 3 days of primaquine with the standard 14. Two had compared 5, three had compared 5, one had compared 7 days of primaquine to 14 days, and one trial compared 45 milligrams primaquine given weekly for 8 days. And in the other question of no primaquine or not, we found 5 trials looking at primaquine given 5 days after chloroquine versus no primaquine. And we found 2 trials looking at 14 days, 10 trials looking at 14 days primaquine versus no primaquine. Just to remind you that this is the amount of trials we had. Now, how many summary of findings tables will I have? 6. Each comparison is a separate summary of findings, right? But in the review, what we wanted was to answer the question 5 versus 14. So we said that would be our first summary findings. Okay. And for that, let's just take this one. Chloroquine plus primaquine 5 days versus chloroquine plus primaquine 14 days. And this is the forest plot you get when those three studies are entered. And we have stratified them into two strata or subgroups. And as I said, these subgroups should be decided in advance. They should be based on biologically plausible reasons. They should be limited in number. Basically, they are like the confounders in a regular trial. So we reason that if you give 14 days of primaquine, we know that because the fever goes after 1 day of chloroquine, people may not complete 14 days. To be sure that we actually testing 14 days, we thought that supervising the treatment will make a difference compared to unsupervised treatment. That's a biologically plausible reason why the results in the trials would differ. So we decided that's one thing we want to explore. Second thing we wanted to explore is, are we picking up relapses or are we picking up recurrences? I mean, a reinfection. The Vivax malaria can you can get two infections, right? And you cannot use PCR to differentiate it because the Vivax parasite keeps on mutating. Okay, so we said within 6 months, epidemiological studies show us it's likely to be a relapse. That is, right coming. Right? After 6 months, it could be relapse and reinfection. We don't know. Okay, so that's the reason why why these were subgroup like this. So we get the result. What is the result? First of all, which is better? Look at the bottom. You'll find the data. 14 days is better. How much better? About 80% reduction in relapse with 14 days compared to 5 days. And there's a confidence interval for that. Right. So now can we tell policymakers, please use 14 days. Can we? Sorry? Eventually. But before that, you have to do great. That's what I'm trying to tell you. You've done a meta-analysis, you got a result, you can't just jump around and use it. Are you sure this is the result, this is the true result? They discover all those factors can give you wrong results. Right? So we are going to apply grade. Good news is you're going to apply it. Okay. So if you find there is a risk of bias, you can either downgrade by one level and you will say serious limitations in study design, or by two levels, which will say very serious. If you find the word very serious, you mean they, you know they've downgraded two levels. Okay, if you don't downgrade, it stays as high certainty. The word quality was the old word for, but basically what we're trying to say is how confident are you? How certain are you? Okay, right. So we know that in RCTs, you can have many reasons why can give you bias, your risk of bias. Right. There are other things also, like for example, if you plan to do an RCT and recruit 800 people, right? And you're, you have a committee, data monitoring committee. Somewhere after about 200 people, they find that one group is doing better than the other. They say you don't need to do anymore, you stop. Gordon Wright got a lot of papers which has examined this. And he says you're likely to get spurious results. Why? Why? Why should you get? Out of the study may decrease. But why should you find that one is doing better than the other with only 200? You're estimated that you need 800 to show that. At 200, you're showing one is better than you. The drug is that good. It's a possibility that you thought that you are getting much better results than you anticipated. How you made a mistake, all that you can do. But first of all, you must remember when you're randomized, you're randomizing to balance confounders. And you randomize 800 people. You stop at 200. On that day, you could find that confounders are causing this imbalance. Right? So the advice is ideally, unless you are showing a pre-specified, I show this much difference, right? In advance, you say, if I should get that much difference, then the data monitoring committee can. Many data monitoring committees have said, no, you continue. And they have found that at the end, no difference. There are papers showing this. So be very careful. You find a paper which has been stopped early for parent benefit. Exactly. That's exactly why you have a control group so you can take care of fluctuations in the course of the disease. Both will fluctuate. What happens? All that is why you're doing a randomization. So the randomization, you estimated the difference between the two treatments is so much. And I need that many people to have power of 80% and a confidence interval that much. Right? So if you do not achieve that, you've forgotten that you may have imbalance. You can try and do a block randomization. Make sure that, at any level you stop, the difference between the two arms in terms of numbers will be within the block size. And most probably, and if you stratify for those potential confounders and done the block randomization, you might be able to get away with stop it. That's one of the reasons. The other is sometimes people use unvalidated outcome measures. They'll make their own scale, or they'll try one primer of their own, lab primer, never tested or published. Those are all things to worry about. Okay? Then you have a crossover trial where you find that there's potential carryover effect. One of my art students in the department did a study with one of the other professors. Good study. When people have schizophrenia, very often because of the drugs and the disease, they have very poor sexual life. Nobody asks them about it. right? So he said, because now sildenafil is available, let's see whether we can use it and whether it will overcome the dopamine blockade caused by antipsychotic drugs. So he got couples and he did a crossover, sildenafil placebo, right? And did good validated questionnaires and all that stuff. What do you think would have happened? Who would have done better? Which would have been better? Sildenafil or placebo? Sildenafil, right? But if there had been a carryover effect, what are the conditions that you have to satisfy before you do a carryover crossover trial? Half-life. What is the half-life of sildenafil? 4 hours. Right. So ideal. You just wait for more than that. Do it the next day. Right? What are the other conditions or the other conditions required for a crossover trial? The condition itself should not change. Right? Would that cause a crossover effect in this trial? Depending on whether you got placebo first or a lot of erectile problems have got a psychological component. So if you take a drug and you find that I'm not better, that carry you to the next also, or whichever way. So that, but that you can evaluate. You can see what is the period effect. When you do the study, whether you got it first or whether you got second, what was the effect? Okay. So there are a lot of sources of bias. Cluster randomized trials. I told you, don't randomize. You just select. You need a lot of imbalances. The conflicts of interest, big problem. Okay, now the risk of bias 2 solves it differently due to allocation process, but they're examining the same things. Now, if you're like for study, you find your meta-analysis graph, you find some yellows and reds and blues, greens. Okay? If they're all green, then low risk, it's unlikely to have influence the result. You don't have to downgrade. Right? You find one or two yellows in some of the studies. Then you have to make a decision. Uh, there is potential problem here. There are some concerns I have, but I don't think they're serious enough to really make a big difference to the result. Not that important. I won't downgrade. But if I find in some areas, 4 or 5 trials, they're all unclear, and I say the concerns, I don't know what's happened here. It might influence the outcome. I may downgrade by one level. Right. And if I find that there is at least one of the trials is in an important area like allocation concealment is a red, they will downgrade. But if I find that there are many trials and many reds, I'll downgrade by 2. Got the idea? How do you decide, do I downgrade? And how many levels I should downgrade by? All of this is there in the Great Handbook and in the Cochrane. So here we have. So what we've done is we have showing you the graph with the risk of bias estimates. Right? So what we found was we had removed this trial in risk of bias. This is a trial done in Calcutta where they say they're going to randomize people for 150 patients. That's sample size estimate based on the relapse rate in the 14 and other arms. And they said we do computer randomization 1:1:1, and we should have 50:50:50. They generated the computer sequence. They said that they use serial number opaque envelopes, and they also stated this will prevent allocation bias. This is the protocol. Right. In the paper, we found there were 15 in one arm, 59 in one arm, and from 40 something in the other arm. And they had completed their samples. So we reasoned there is no way they could have got that if they had actually taken serially envelopes. Something went wrong. They've at least given us a result. The main paper was the molecular genetics of the vivax, but they'd done a trial also. Okay, so we decided that we are not going to include this study because there was considerable risk of selection bias and poor compliance with treatment. They themselves said, we are not sure that the patient took their treatment. So then why should we include this in our guideline? So we had written in our protocol itself, either serious concerns about some studies we made in sensitivity analysis, we will remove, we will not use it in our guideline. But what we are going to now decide is only on this. What does that tell you? 14 days versus 5 days. Which is better? 14 days. How much better? 10 times better. So if you want to express it in percentage, it's ridiculous. You can only say 10 times better. This is the problem. When you have something like this, what is the relative risk reduction? Express as a percentage is very difficult. Okay, it has some bearing on grading. Okay, so should we downgrade for study limitations or info bias? What are we going to downgrade? That estimate from those two trials. We downgrade. Don't look perplexed, man. Say it. No, there's no bias. Why should we downgrade? Okay, you get the idea. Okay, so we are not downgrading. So our quality certainty of evidence at this stage is high. Okay. The next one is inconsistency in the results. As you know, it can occur. We have statistical inconsistency, but it can occur due to clinical methodological biases and even chance. So what we need to know is, can we detect it? Can we test to see if it is due to chance or not due to chance? And if it is not due to chance, how much of it is chance? How much of it is not chance? How much of it is true inter-trial differences, right? And if it is not chance and your inter-trial differences are quite high, right? Why is it the drug is working better in one trial and not in the other trial? Can we explore it? That's what you'll do your subgroup analysis for, right? And if you try exploring and it still doesn't explain anything, then what are you stuck with? Should I combine? Should I not combine? If you want to combine, then you have to say, I have to give each trial equal weight, more or less equal weight. That's when you'll use your random effects model and incorporate it. If you use a random effects model, automatically it becomes an imprecise result, inconsistent result. You're acknowledging there is inconsistency and incorporating it. You cannot say there is no inconsistency if you use a random effect model. So if you're starting over the random effects model, you should change it to fixed on just click the RROR tab and see is there a big difference. If there isn't, don't downgrade. Okay. So identifying important inconsistency. How do you identify their inconsistency? Overlapping confidence intervals show there is no inconsistency. Non-overlapping confidence intervals tells you there is some degree of difference between these styles. Okay, that's one. Now the next thing, what do you do after that? Yeah, you do your chi-square test, which actually, because the chi-square test is not a very powerful test when you have a small sample size, you're not going to say, I want to be 95% certain this is not. You say even 90% I'll accept, right? So you're trying to ask the question, are the differences in the results of the trials chance difference? There is random error. What you're talking about basically is within trial variance. In the trial, these things are all chance, right? And you're talking about the trial variance, which is that first part of the variance. I square denotes inconsistency that is not due to chance. It's actually due to the within trial, between trial variance. Okay. It's actually derived from the chi-square value. Chi-square value is called the Cochrane Q, right? And that's the formula. If you look at it, it's 2 minus degrees of freedom divided by Q. You're looking at the rest of the chance of it and expressed as a percentage. Okay. Now, they say normally 25, 50, 75. Many papers still use this cutoff, but that is not a very sensible thing to do. And the current guidance is that there is a range of values which will cause a lot of grief to you all because you'll say there's a lot of overlap. How do you then decide it is? It is when you have to use your computer. So it depends on the magnitude and direction of effect. we worked through some examples, and you also did some examples. You did some examples yesterday also. And the strength of the evidence from the p-value, how certain are you is not a chance difference, and you can even get a confidence interval for your I square. These are ways that you can actually look at it, right? But if you can explain the heterogeneity in a subgroup analysis, you don't need to downgrade. Okay? Unexplained heterogeneity also may not be downgraded if you're only talking about difference between large effect and small effects favoring one intervention, not the other side. I'll give you an example of that. Unexplained heterogeneity that is incorporated by a random effects model might denote that the denotes warranty downgrading, but you have to decide. Okay, you tell me, is there important heterogeneity here? So what is the process? Are the confidence intervals overlapping? Right? How certain are you from the p-value? P-value tells you that it's not a most likely a chance difference. And your I square says there is nothing, only chance. So you don't downgrade. Right? Agree? Yeah. What about this? So the confidence intervals of the first study and the last study are very overlapping or not overlapping. Your p-value for the chi-square tells you you're more than 99.999% sure these differences are not due to chance alone. Your I-square tells you that 81% of these differences is due to something different in the trials. Only 19% can be attributed to chance. Right? You understand how to interpret the I-square? Only 19% of this is a chance difference. The rest of it is something wrong, something different in the trials. Okay. If you find this like that, what should you do? What model have they used? Fixed effect. Right. What's the next step? Oh, see, I'm trying to trick you. It's not random effect. Can you explain it? Subgroup analysis. Can't explain it, then you might decide, do I want to combine it? If you decide to combine, then change to random effects. Okay. What about this? I don't know what they're comparing, but there's subgroups up to 7 days, 4 weeks, and more than 4 weeks. Right. And uh, what model, what have they use? Method or meta-analysis. Method, not model. What kind of outcomes are there? You saw log risk ratio, no? So this is generic inverse variance. I showed you yesterday in that trial, 14-day trial, we had cluster randomized trials and parallel group trials. You want to combine them, I have to convert everything into a log risk ratio, and I can combine it. And I also told you if you're doing observational study where you get adjusted risk ratios, right? You can plug the adjusted risk ratio with the calculator which I showed you and combine all the studies. Okay, so tell me, should we downgrade? Overall I square at the bottom is 65.1. And within the subgroups also there is heterogeneity. Should you downgrade? What is the pooled effect and what is the pooled effect in the subgroups? Favors treatment or favors control? Right. So there's some disagreement in that heterogeneity means a disagreement within the trials about the result. So what are they all are saying that favors control. One trial is on the fence on going to the other side. How much weight does that trial have? 10%, right? And the effect estimate is 0.4, 0.29 to 0.57. That's a pretty good effect, right? You can do one thing, just remove that trial. How do you remove that trial? Unclick it, right? It will not change. I can guarantee you it will not change. So, overall, the disagreement is how effective the trial compared to control, not whether it is worse than control. So when you're arguing among yourself, but policymakers say, "Arey, yeah, give it to me, man. You're telling me it's good." So you fight among yourself. How good is it? I'm not bothered. I want it. Right. So when you have small effects and large effects, but they're all in the same direction of effect, that you need not downgrade. But you must explain it, not downgrade it for it. Not only do you explain when you downgrade, but if there is something, some reason which you can explain, not downgrade it for inconsistency, even though I square will is, because the difference between small magnitude and direction of effect was all stars were the same, only differ in how effective it is. I didn't downgrade. So, what model have they used? Random effect model, that study is getting more weight. If you change the fixed effects model, it will get no weight. Yeah, because you look at each study, within the studies also the effect estimates are scattered. Dr. Mahota, this morning there was one quite a long time that slide was up, showing all the effects in a straight line. Right? Here all the effects are not necessarily in a straight line, they are far off, slightly far off. And it's telling you there is inconsistency. So when you say 0 to 60, 65 to this, the range. Okay. So if you say you're going to downgrade, right? You have to give a reason. Downgraded for serious inconsistency, because if you say it's not downgraded, you don't have to mention. You can even put a footnote saying not downgrade, right? If you don't downgrade, certainty of evidence beside. If you downgrade by one, it comes down to moderate. So this is what we are really trying to do here. Okay. Now this is our example. We are only taking the first thing because we are not bothered about this. So if we downgrade for inconsistency, pre-tests, eyeball tests, with the confidence intervals overlap, square value 0.14, right? But there are only two trials, so chi-square is really not very powerful enough. I-square says 53%. Downgrade. Why? Don't know. Because I say why doesn't mean automatically no, but why? Just look at the graph. Look at the graph, forest plots. Are they disagreeing about whether the drug works? Risk of bias. We're looking at inconsistency. Inconsistency is the effect estimate here, and this effect estimate is here, right? We want to know whether this difference is something we should worry about, right? So, what was the previous slide? What was I trying to explain in the previous slide? Yeah. Difference here is not whether 5 days is better. Difference is how effective is 14 days in the two trials. Small effect, large effect. Okay, so that is not a reason, necessarily a reason to downgrade. We're already subgrouped by 6 months, and that's the only major sector that we have. Yeah, that's the direction of effect is that side. Because all the trials are saying the same direction. There is heterogeneity, but that's not important for us, enough for us to not trust the result. See, we are trying to see how confident are we in this result. We went through risk of bias. There is no bias, so that I'm confident in that result because of bias. Okay. Now we are looking at inconsistency. Okay. I'm saying there is some inconsistency, but not a serious inconsistency. That's the word serious. If it was serious enough, I thought it's serious enough to actually make a big difference to does it work? Okay. The other thing you can also do is change it to random effect. B, does it make the difference to the result? We tried that. It didn't make a difference. 14 days is better. Okay. So that's why we are not downgrading for this. So for us, these two characteristics, we have no serious concerns. So certainty of evidence is high. Now, next is indirectness. So indirectness, you're looking at the population intervention, comparison, outcome, the timing. So, for example, we were doing a thing on antibiotics for Shigella dysentery. So it's a this title because so many antibiotics are used for Shigella dysentery, right? And so we grouped them all, fluoroquinolones versus whatever. But we found when you were looking at the grade, none of the children, none of the trials included children who are malnourished. Is that important? Malnourished children get Shigella dysentery, they die, right? So we had to downgrade for indirectness on that. You know, the common problem, especially in overcrowded areas and stuff, no? If you don't have evidence for a huge chunk of people, that's why it's important to read the exclusion criteria and inclusion criteria. You know it by heart. Then only you can do grading. Okay. The intervention. So we did a systematic review on uh, daily versus weekly intermittent treatment for childhood tuberculosis. We found 4 trials. All those trials use regimens which are not used today. Not relevant to us. Indirectness. Serious, very serious indirectness. Right? Then you'll find trials where one arm gets haloperidol 20 milligrams and compared with risperidone 2 milligrams. That's not a fair comparison. Right? Downgrade. Indirect. Because in clinical practice, we are not going to use 10 milligrams in be flexible dosing. Right? So that is another reason. Outcomes. So only proxy indicators are there. So you will downgrade your confidence. Right? Timing. Some people will they're doing timing of many things. When you give the injection, also when you assess the outcome. If they are deviating from what you normally do, then that confidence in that evidence for your purpose is gone. You downgrade. Setting. Setting health delivery system can also matter. So it may not apply to my health system. So here, since you may have forgotten when you read the paper in detail, all the papers together, I'll tell you what the problems were. Trials excluded children. These 2 trials did not have children. And the trials were done in area of low malaria transmission. Right? So that may change in areas of high transmission, relapse rates and stuff. 14 days primaquine is good, but we don't have any direct evidence on this. That plus the fact that these were done in areas of low transmission reduced our confidence a little bit on applicability. So we downgraded by 1. And we put a note. Downgraded 1 level for serious indirectness, not serious, serious evidence. Because the trials exclude children were done in areas of low malaria class. Next one is imprecision. This is where it really gets interesting. 2 factors matter. One is the width of the confidence interval will change your decision on whether you should use the intervention or not. And the second thing is the optimal sample size. Both you have to look at. Okay. So you're looking. Sure. That's not your interest, don't worry. You're only asking a question about adults, then don't worry whether there are no children. You're not interested in that. But here, Shigella for treat for everybody. That was our aim. Okay. So suppose you're looking at your minimum important distance as 10%. You set it in advance. I need 10% this side and that side. Anything above that is what I consider clinically appreciable difference. Okay, the first one, what would you say? Is there imprecision? The first one on the top. Upper limit and the lower limit both show appreciable difference, right? So, appreciable benefit, so that's a precise result. Okay, second one, one end shows appreciable benefit, the other end shows non-appreciable benefit, right? So, you might be a little confused, should I use? It will be very good. It has not crossed over the other side. That level itself, you're saying I might not. We looked at no. Sometimes lower limit confidence interval is 0.99. I don't know whether it's going to work in the real world because possibility only a 1% difference. Right. So this is an example of appreciable benefit, but also non-appreciable benefit. You will downgrade by one. Serious imprecision. Is that clear? Okay. This one, this is a funny one. What? Both. Both estimates are non-appreciable. So is it precise or imprecise? Should we downgrade? It is precisely useless. That's why you're not going to downgrade. That is not, you're not going to use it. Upper or lower limit is not within what you want. So it is a precise result. You don't have to downgrade it because the result itself is telling you that it is not. This one is serious imprecision because it goes into the other side. Small harm, some appreciable benefit. Okay? And small harm is maybe, 1.1, something like that. Okay. So downgrade by one. The one in the middle, again, I'm not going to use it. This one, small harm, appreciable benefit. Again, like the first one. This one, last one, uncertain. So what are you going to do? Downgrade or shrug your shoulders? Very serious. No. Very serious imprecision. It could be very, very benefit for one, very, very beneficial for the other. That is serious confusion. Very serious confusion. Right? This is the way we think about precision. Okay, will I use it? Put a lower limit. Both say I'm not going to use it. Give me a precise result. Second last. Yeah. One is saying that there is some benefit, the other end is saying non-appreciable benefit. Third last, the red one. Small harm and appreciable harm. The thing is, this end is not really worried about. This end, it could be useful. It could be an important thing. If it crosses the line of no appreciable benefit, it creates uncertainty. Right? If it crosses the line on both sides, serious uncertainty. Very, very serious uncertainty. So when I'm looking at an outcome and it says it could be very harmful, it could be harmful, or very minor harm. Same as saying it could be very good, very little. It's an outcome for harm. So anyway, if we downgrade for imprecision, lower limit is what? Double the efficacy. In effect, 200%, 100% better. How much more than one? Right? So if it was that, would I use? Another one would I use? Anyone? Would you use? Would you not use? If you found that that drug, the risk ratio is 2.3, do you consider that a good result? Yeah, obviously. Then what you should do? Downgrade? Don't downgrade. Put a lower bound to the 95% confidence. It will show a clinically appreciable benefit with 14 days. So no need to downgrade. But you can't not finish your grading here. You also have to look at the optimal information size, right? And there was a thing saying rule of thumb 400 events, right? You will not find that in many trials. Events, not people. Events means 24 plus 2, only 26 events. Okay, so what you also have to keep in mind is there is a risk reduction, the power of the drug, how powerful it is, and the population they're using it in. This is something you have seen, this graph. So on this graph, we have to plot whether we meet the optimal information size in terms of the number of events. So what do you need from this? What is on the x-axis? Control group event rate. And what's on the vertical axis? Number of events. So what you need to do is calculate from that forest plot what is the control group event rate and what is the number of participants and what is the relative risk reduction. I'll give that to you. The relative risk is 10.05, ranging from 2.82 to 32.86. We have totally 26 events, and the control group event rate is point. Okay, so will somebody come up here? Plot it for me, please. So let's just see where should the point 2 be on this graph. Our control group event rate is point. That's what? Yeah, okay. Then the relative risk reduction 10%, 25%, 30%. Where will ours be? 10.5, it's at the relative risk reduction. This is 1 minus, but in this case, it's the other side. Right? So where will the graph? Will it be like this? This? Or where? There? Will it go up or below 30% or below? Right. So if I start here, will it be 100 or will it be even lower than that? Much lower. Much lower. So from that particular perspective, I don't think this is a problem. Because you have a relative risk of that much. Powerful difference. You need fewer people to your kids. This is always something to keep in mind. If I have huge difference between drugs, I need a small sample. You have a small difference between drugs, I need a huge sample. Okay. Together, in general, a sample size of more than 2,000 people in both the arms together. Ideally 4,000, but if you have more than 2,000 people in both the arms together, not events, right? That also is an optimal information size. So we have 186 sample size. What is the sample size? 180, yeah. 186 participants, right? So if we are looking at this here, and our control group event rate is 2, yeah, it will come in this line. It will come much lower than that. That is another example, will be easier to see. So we are not downgrading for precision because appreciable benefit and sample size and events have been made. Any other thing you have to look at is reporting biases. Now, ideally for reporting biases, you are trying to make sure that all these biases are not being was in your chart. So we only have 2 trials in this. We cannot do a final plan. Ideally, you need at least 20 trials. 10 they say is a minimum, even 10 is not informative. Okay. But this is actually an update of a previous review. And the Cochrane search methods research everything, including they asked the WHO division, do you know of any other trials? Right? So we are fairly certain there was no trial large enough to make a difference to our results at the time of publication. So we are also a final things in moderate certainty evidence because we downgraded by 1 for indirectness because of the children and the transmission. Right? So that's our grading, and that's what our summary of findings statement looks like in RevMan. When you import it back into RevMan, this is what it will look like. And it talks about Vivax parasitemia, 30 days. So this is all the stuff you have to make sure it's correct. What is your outcome? And what is your follow-up period? When was the outcome measured? So these 2 trials were between 3 and 6 months. Okay. And it tells us that time equal 14 days, you can expect 21 relapses per 1,000. And with 14 days, with 5 days, you can expect 183 more relapses per 1,000, 49 more, and 742 more. Big difference. Okay, if you're using 5 versus 14. Comes from this relative risk of 10.05, which you just saw from Revman in 2 studies, and you got one rate there, moderate certainty evidence. That means Remicade 14 days will probably or is likely to result in a substantial difference in relapse rates. How much you have to quantify what it is. This is a substantial difference. Okay. That we also have that. And there are 2 other outcomes we had selected. None of the papers reported any of these or serious outcome adverse event. And you have to have a footnote. So the first thing says that there were 3 trials, and the data from the third trial were not pooled. They're not hiding it. They say this is the reason why we didn't pool that. Okay. Then we go and say no limitations, no serious inconsistency. We are explaining, even though there's 53% I square, the direction of effect, we're all agreeing, and we did a random effects what it can change the result. Okay. And serious indirectness, we explained why. And no serious imprecision. This is how grade table is come. Yeah. Sorry. Those 2 trials were done in low transmission areas. Yeah. It's the reason why we're putting all these explanations. So you can decide. So what I'm saying is, the authors are doing a grade assessment. And the next step is the people who want to use it have to read this and say, does it apply to me? The second step. Right? We are giving you the evidence from the trials, and we are saying it is likely that will be indirect. In our discussion also we mentioned. Okay, but you're very right. If you do not want to, you want to only in adults, you guys are okay. Okay. So the more details you provide on what your thinking was, the more useful it is for people who are reading it. Okay. So we put the first version of the review and took it to the ICMR. They gave us a patient hearing. Vasanta Muthuswamy and Lalit Kant and all the ICMR people from all over there. And we told them, sorry boss, this is good evidence. Publish it. So they are very happy. They said, we should be using this. Yes, you should be using it. You should buy. They said, we buy for ICMR. So no, that's taxpayer money. Buy for the whole country. So I think we negotiated with Wiley and we could price ICMR bought a national license, which was renewed till, I think till about 2014 or something. The whole country had access to it. Then Cochrane changed and everything else changed. We don't have. So this evidence update was the thing we used to do on page. Question, answer, 1 or 2 graphs. Right. It clearly showed that 14 days is better. 3 months later, malaria policy changed. That's 14 days. And a year later, Park and Park textbook changed. To see what an impact the review can have on policy. The group of authors who were doing Shigella review, they were a lot of complex. These are all community health medicine guys. One of them said, senior chap, he came and told me, sir, I see patients. I love seeing patients. It's, I said, okay, how many patients will you see in your lifetime? You change one policy, it will help so many people. It's the value of this. But then there is the thing called the evidence footprint, right? So I looked at the guidelines year after this to see where is the footprint. Okay. No Cochrane review. But they said WHO guidelines. I said, okay, let's see what the WHO guidelines. Went to the guidelines for treatment of malaria, says very clearly you should use 14 days for primary, except for pregnancy and G6PD. Strong recommendation, high quality evidence. You see this, then they have applied the grade process. We have provided moderate certainty evidence for this thing. They have made a one of the things they do is they asked different questions from us. At that time they wanted to know should we use 14 days or less than 14 days of primaquine, right? And the next question they asked was should we do 14-day courses of primaquine reduce relapse rates greater extent than shorter courses in people treated for AIIMS malaria. This is their evidence table. That is evidence to policy decision framework, right? And they've taken 7-day course of primaquine added to chloroquine reduce relapse to a greater extent than chloroquine alone. High certainty evidence. That's from our review. 14-day courses of primaquine added to chloroquine result in fewer relapses than 7-day courses. We only had one trial, alternatives, low certainty evidence. But keeping that together, they have overall said overall quality of evidence for all the critical outcomes is high. And that's the strength of the evidence, high certainty. They are saying overall certainty is high. And the strength of the recommendation, they're saying strong recommendation. That's their recommendation. And they give you the evidence table. This is straight from our review. See what happened with Revman, you can create a summary of findings table, and there are various ways it can be presented. One is like the summary of findings table I told you. The other, you just click with the pen, choose it, you get this table. Presents it in a different format. Okay, the relative risk of 0.60 and all comes from our 14 days outcome. Same thing. Okay. And they made a decision of high certainty evidence. Okay, so they basically taken that all the other trials showed 3 days, 5 days, 7 days, all showed less efficacy than 14. The next one was our 14-day course of Penucan versus 7 days, one study, but also different. So this is the way it's done. What's the time? 15 minutes more. Oh, good. Now it's your turn. So now let's finish this. Observational studies and non-randomized studies. Cochrane advises these 3 categories are good kinds of observational studies. Because you need to have 2 groups, no? Have a control. So they say control before and after study. What do you mean by control before and after study? Control before and after. Suppose you decide you want to roll out a program, health program, right? Ideally, what you should do is identify all the areas you want to roll it out. You do baseline assessment in all these areas, and you roll out the programs in some of those areas. Say we will assess the outcome, and if it works, then we roll out in the other areas. So you have a control group, control observation on both sides. Then after the trial, you again do the outcomes on both. In the area you rolled your program out, and the area you did not roll your program. Why is it important? That's the only way you can say your program made a difference. Because in this country, there are so many things happening. So unless you have a control group without your intervention, you cannot claim we did all this. Which is why you'll find in many of these programs, you very rarely find outcomes. You only find process indicators. How many doctors were trained, how many nursing homes we did, not what happened. So you can't compare it with, you can compare it with some historical thing in the past, but not simultaneous. That's one design. What is an interrupted time series? According to the effective practice and organization or care group, basically you have to have baseline assessments, at least three of them, separated by about a month or so. Then you have to have after your intervention another three. That's an interrupted time series. Okay. And of course, you can have your cohort studies. So they are considered to start at low certainty and can be downgraded further. But if you don't downgrade them, you can consider increasing your confidence in them. So if you have downgraded them, or if you've got uncontrolled case series, you can start at very low. If you downgrade from low, you go down to very low. Once you do that, you cannot upgrade, right? And if you have uncontrolled case series, they start at very low. So some of the limitations could be like in case control studies, you didn't match properly, or overmatched or undermatched. And some of these cohort studies, you didn't follow them long enough for the outcome to occur, or your exposed and unexposed cohorts, you made a mistake. We went through that when in the previous session. That you can consider downgrading by one. Flawed measurement of exposure and outcome difference in the measure recalled by case control studies, you can consider going down. Different surveillance or failure to control for confounding, no way to go on that. All of these are reasons where you can consider downgrading. Okay. But if you do not have them, you can consider this for these three factors. Strong association, which I mean is, this is an example that's given. You want to know what happens if people wear bicycle helmets and head injury. You cannot do a randomized control trial. The only thing you can do is an observational study. And they found from this observational study, meta-analysis, there were no threats to the done well. They showed that bicycle helmets reduce the risk of head injuries in cyclists. Odds ratio 0.31, confidence interval 0.26 to 0.37. You're looking at the lower limit of the confidence interval, and you say it is a pretty large effect. There are no limitations in the studies. So I believe that even though there could be some selection bias, and I don't find any major reason not to believe this, I can upgrade my confidence in this by one level. On the other hand, if you find that, again, observational studies, meta-analysis, no limitations at all, show that warfarin prophylaxis reduces the risk of thromboembolism in patients with cardiac valve replacement, right? And your least estimate of your relative risk is 0.24, 76% reduction. So I'll say this is a very, very good effect. I can go up even by 2 levels. Automatically, it becomes high certainty evidence. Okay. The next thing you may consider plausible confounding. You have studies where you find only sicker patients get the experimental intervention, yet they fare better than the other. Then you could suggest that it could be a confounder which actually has reduced the power of the effect, and you might want to give more. I'll give you an example. This is from a trial. Uh, we've got a center where we have children with learning disabilities and autism. They come for treatment, and it's a residential facility. The parents are admitted, caregivers are admitted. They are trained to look after the child. Right. So when they were setting it up, they were wondering how do we teach them? They did a trial where they got parents who were eligible and did baseline assessment of their attitude towards their children with disabilities and their confidence in managing them, and randomized them to either get didactic teaching. You've got a very good special education teacher, or problem solve. The other group got problems and they had to solve it. And they did the same outcome measures at the end. Which group do you think would have done better? Problem solving group got better scores in confidence and attitude and stuff. So are you happy with this result, or could there have been any confounders here? Sorry? No, that's all balanced in the randomization. What could be a confounder here? Sorry? Baseline variables they measure. No? Everybody was educated about this. One was through through problem solving, the other was through didactic teaching. I tell you what, I told you it's a resolution facility. Does it make a difference? Others will sit after class and say, what happened to you today? And so this Susan who teaches very well. Well, I say, Bhargav, she's fantastic. She's the way she solved the problem. What is this called? Contamination. If there was contamination, what would you expect in the result? If there was no contamination, what would have happened? The result would have been better. That's one example of plausible confounders were there. If they were not there, I'd have got an even better result. Okay, so then you can upgrade. The third thing is a dose response. Across the studies, you're finding there is a pattern. It shows a dose response relationship. Higher dose in one study, effect, lower dose in the other study, lower effect. So you can see a gradient. It could be another reason to say from this body of evidence, I am confident that this is the way to develop. It could be a reason why you want to upgrade. Okay, now going to have lunch until you show mastery. I'm sorry about that. You've eaten enough for the past 5 days. I've been watching. Okay, I'm going to move to falciparum malaria and look what our guidelines say. They say you can use, if you have malaria, you can use artesunate, quinine, artemether, or RTT. Right? Four choices. Okay, where's the evidence footprint? WHO. So let's go look at WHO. WHO said IV artesunate should be used in preference to quinine for the treatment of severe falciparum malaria in adults. Strong recommendation, high certainty evidence. Now, you guys are going to be helping frame guidelines for the country. I know that. You're eager enough. How can we come to this conclusion? What should we do? What's the first step? Before that, before the very first step, here's your PICO. Here's your PICO. The systematic review means you produce systematically. It should be there. What's your PICO? Start with the P. In patients, I'm going to say in patients diagnosed with severe falciparum malaria, plus treatment with artesunate IV reduced death compared to treatment with quinine. Okay, next step. Shout. What are you going to search for? Huh? What are you searching for? Say it. No matter when, say it. Lunch is waiting, say it. What are you going to search for? RCTs. RCT, somebody says RCT. Anybody saying observational studies or anything else? So, search for POC for a systematic review. You'll find this Cochrane review, artesunate versus quinine for treating severe malaria. If you look at it, you have to first ask yourself, can I trust this review? Before I want to see whether I can use it. Right? So you go and look at AIIMS. That is a critical appraisal tool for systematic reviews that include randomized or non-randomized studies of healthcare interventions or both. Okay, you can download this as open access and it has a series of questions. Okay, first question is, did the research question inclusion criteria include the components of PICO? Yes, I read the review done. Did the report of the review contain? So what I'm doing is making this bold and well is confident to make in AIIMS. Okay? Did the report of the review contain an explicit statement that the review methods were established prior? Meaning, was there a protocol, right? Protocol, and was there any deviation from the protocol? And did they justify it? That's also fine. Did they explain the selection of study designs for inclusion in the review? Yes. Did the review authors use a comprehensive literature search strategy? They did. They gave us search terms for everything. Did the review authors perform study selection in duplicate? Yes. Did they perform data extraction in duplicate? Yes. Did the review authors provide a list of excluded studies and justify their exclusion? Yes. Did they describe the included studies in adequate detail? Yes. Did the authors use a satisfactory technique for assessing the risk of bias in the included studies that we included? Yes. Did the review authors report the source of funding? Yes. If meta-analysis is performed, then the review authors use appropriate methods for statistical combination, like fixed effects, random effects, that kind of stuff. If it is performed, did they assess the potential for the impact of ROP in the meta-analysis? Yes, they did. Did the review authors account for risk of bias in primary studies when interpreting, discussing the result of the review? What do they mean by this? Did they have a grade table? That's what this means. Did you link evidence and bias and other things? Okay. Yes. Did they provide an explanation for heterogeneity? Yes. Did perform quantitative, they did quantitative, did they look for application? I mean, did they in a small study? Did they actually search for it and report it? Yes. Did they report any potential conflict of interest, including any funding they received for conducting the review? Right? Yes. So what you have here is 16 items, 7 items are considered crucial. And how you make a decision is this: high confidence in the result of the review, no or only non-critical weakness. Where it's fine. Moderate means more than one non-critical weakness, no critical flaws. You can consider that. You can also use it as an editor. Again, a journal. You look at the use Amstar too. If you find no flaws, that's it. You find more than one non-critical weakness, not critical, you can even ask the author to please explain this. And you can say accept, it's valid. But if you find one critical flaw with or without non-critical weakness, you have concerns. You ask them to revise seriously, or you can yourself, or the policy group, update that and change that. If you find more than one critical flaw without non-critical weaknesses, you should not use it. That's the first step when you're looking for systematic review. Do it on start two. As far as we are concerned, this is very good. This is the results for the outcome of death. 1, 2, 3, 4, 5, 6 studies done between 1989 and 2005, in which across the studies, 975 people were randomized to get artesunate, out of whom 133 died, and 963 got quinine and 214 died. And that's the individual risk ratios and confidence intervals. That's the scatter plot, that is the forest plot. And which study got the biggest weight? How much? 73%. What is your prayer? Dundrop should be free of risk of bias. What's the overall result? By how much? 38%. Best estimate? 39. Least estimate? Right. So that's the thing. Absolute, you can do absolute risk difference comes to about anti-4 per 1,000, and the NIP is around 12, and range from 9 to 18. So now can we draw a guideline and say we should all use artesunate instead of quinine? Hold your horses. Should we tell ICM or tell the ICM or tell South, please go and tell them only artesunate? Yeah, next step is to grade. Obviously. Right. You have to apply these criteria, study limitations. I'm giving you the and you downgrade and so by how much? Right to what is the outcome? Why are you downgrading for blinding? Doesn't matter. It doesn't matter. What matters? What could matter? Allocation concealment. So, two trials where allocation concealment was at high risk of bias. Keeping that in mind should be downgraded. Dondorp is fine. Only blinding is the problem. Outcome is death. You're talking about allocation concealment. Why does it matter? How will allocation concealment not be good affect the outcome of test? Real outcome. Allocation concealment balances confounders. So if you have sicker patients in one arm, they're more likely to die. Right. So that is a potential thing. So you must see, did it happen? It could happen. Risk of bias. Is it likely to have influenced our results? How do you know? You have to look for it, man. You've got a good program. You can easily subgroup them according to adequate allocation concealment, inadequate allocation concealment. What do you find? That will make a difference. Did not make a difference. So you do not need to downgrade. You have to explain. Not downgraded for risk of bias because even though this is what happened. You understand? This is how you did. Good. You have done well. Next, inconsistency between results. You know all that. This is what you're going to look for. And you're going to tell me, is there inconsistency? Before that, I'll give you an example. Is there inconsistency in this? Why? Confidence intervals don't overlap. Your p-value tells you more than 90.99.999% sure this is not due to chance. I square is 94%. Right. What's the next step? What's the next step? We know there is iterating. What's the next step? And for what characteristics? You need to know that, no? I've given you a hint in this. Look at the study IDs. Does it differ from the usual way of showing study IDs? Three alphabets after that. First one says SEN, second one says TZE, countries. Countries where? Africa. These are countries in Africa. So you have to think of biologically plausible reasons to subgroup. If you know the geography of Africa, you can figure out what's going on here. West Africa, East Africa. Where is Tanzania? East Africa. Right? Where is Uganda? East Africa. So you have to group them by the East Africa studies and West Africa studies. What do you find here? What is the difference show? Countries in East Africa, AL6 works better. Artemether, homofantine 6 dose. Countries in West Africa, the other drug works better. What is the biological explanation for this? None of you work in infectious diseases. What is the explanation for this? Sorry? Any other? Any other? What are we evaluating the effect of drugs on? On a parasite. So what can explain this? Geographical differences in drug resistance. Right. If you can explain this, you are confident of the result. Right? If you're going, you'll say if you're using for this thing, not our review, we'll use an example. Right? So you have to think about the results. But good. We're back to our study. Is there heterogeneity here? Could we downgrade? Great. Fantastic. See, you're learning. Right. Now the next one is indirectness. So from the studies, you know, only 2 of the 6 studies included children. 5 of the 6 studies used IV artesunate, 1 used IM, and only 4 trials gave a loading dose of quinine. Downgrade, and if so, how much? Or What I'm trying to say is there did have influenced our result. Right. So what you have to look for it? You have to try and prove it. Okay. Your wish is mine. Anything you ask, I give you. Comparing. Not tell me. And you know, the vast advice that parts that is very good. When we say the same for children, we don't know. We don't know for children. But only two trials, sample size is not very much. Right? So what should we do? Downgrade or what? Fantastic. You need a separate summary of findings table for adults where we have confidence it works, and you need a separate summary of findings table for children where we are unsure. That's what they finally did. Because they also knew there were ongoing trials. And they said when those trial results come out, we will formally publish the guidance for children, which is why that guidance said in adults. They were waiting for the update. Okay. That's a good way of doing it, I thought. Now, IV artisanate, IM artisanate. What does this show? IV we clearly know works. IM we don't know. So we are not going to talk about IM. You want to use it, up to you. But we are only recommending IV artisanate. You see, that's the way you can pragmatically make the decision. Low loading dose or loading dose. Doesn't make a difference. So they are not talking about it. You want to use, you use. Don't use, it doesn't make a difference. Okay. So for indirectness, we are not downgrading high certainty evidence. Imprecision. This is where, okay, you know this now, I won't repeat all that. You guys are smart. So I'm going to give you examples. This is an example of total failure for falciparum malaria, 28-day adjusted risk ratios from 3 hour CTs, comparing AL6 and AQSP. Is there imprecision here? Downgrading? No. No serious imprecision. Both upper and lower limits are appreciable benefit. What about this? The outcome is gametocyte carriage at day 14. Relative risk is 0.21 confidence interval to 0.90. So what is your decision? Is there a serious imprecision? Should you downgrade? So some people will say 10% is not enough for me, right? And they'll downgrade by one. Some people will say 10% is enough for me. They will not downgrade. So you have to set your minimum appreciable difference, right? But only one. You downgrade only by one. Okay. Yeah. Outcome is harm, serious adverse events, including death. Including death. Downgrade or not? Yes. Who says yes? When you know something, say, hold that you know it. You can't say anything. Bosses said yes. Justification, sir. Not only includes one, there's very serious imprecision. Right? At one end, it says one drug has got appreciable benefit in no, causes a lot of harm. Right? And the other one says 10% that is important. It's a public health intervention. 10% is too much. So you'll say, I've got serious, very serious imprecision. I will downgrade by 2. But it depends on where you set your limit. So for harms like death, which can affect a lot of people with an intervention, your bar is very low. Okay. Exceptions are sorry. No, 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 no. No, that is a different outcome. This is a this previous outcome is gametocytes. I'm looking each outcome we are looking separately, and making a let's not get into that, sir. I don't know. I have no idea. Let's move on. People waiting. I'll talk to you about it later because I don't know enough about malaria to tell you that. Next. But you have very rare outcomes. What they advise you to do, don't look at the relative risk because the confidence will be very wide. Look at the risk difference. then you can see, is it out of so many people, so much, people more, 3 people more, then you make that decision. That's what they say. It will be very, very rare outcomes, especially if you've got a large sample size in events. Okay, you know this thing for sample size, optimum information size, and all. Is there imprecision here? Is there imprecision based on the confidence interval? No. Then sample size, you've got 1,938 people and 347 events. Right? 400 events. So for the you need the relative risk reduction and the control group event rate. Relative risk reduction is 0.38, control group event rate is 0.2. So if you look at it, I plotted it for you. You need around 180 events. We had 347 events. Okay, so that's cool. As far as the events is concerned. For here, we need around 1,000 participants, or maybe less than that. We had 1,938 participants. So no problem as far as sample size also is concerned. So right now, absolutely no reason to doubt it. Publication bias. I'm giving you another outcome. In the same review, there is a neurological visibility that is shown. Also, malaria can cause a lot of problems and neurological visibility. What do you see here? Artesunate versus quinine. Number of events is very little. Right? So ideally, you should be looking at risk difference. But anyway, whatever you do, you have to keep in mind that quinine, more people were saved with artesunate. More people died on quinine. People who are alive have got some neurological disability, right? But very little, 8 out of N3. Probably the methods are not even in some studies. So those are the kind of things that you have. So if you downgrade, you have to. So application bias. Somebody was asking me this morning what happens here. So as was shown in the graph, what you have here is a line of no difference one, right? Then you have another line which is the effect estimate, right? And if you're using a fixed effects model, larger studies with more events and more control group risk will have a narrower variance and narrower confidence interval. They get the most weight. So where will they be? They will influence the effect estimate. They'll be on top, larger size, right? And by a play of chance, you'll find all the others will fall on both sides. That's what you expect, provided you have a large enough sample of trials. Now, what you're looking for is where you miss the small studies which are negative. Why? Why should you worry about that? Because if you don't have them, what will happen to the effect estimate? It will shift towards the other side. So you're looking to see, have I made an overestimate of benefit because the small studies are not there? Okay, but in this particular meta-analysis graph, you have too few studies to actually look at the funnel plot. Also keep in mind, this is a WHO. They have access to all the malaria trials. They will know whether if you have a small trial, is not going to change the outcome in this big outcome. Okay, so there's no high certainty evidence. So this is their evidence table, right? In which they said there are 6 randomized trials. No study with nothing, none of those limitations. They show 13% risk of death with AS and artesunate and 22% risk of death with quinine. Right? The relative risk, everything 84 few. So from the review, and they say high certainty. The neurological sequelae, they say very low certainty because there was serious indirectness and very serious imprecision, right? And others also they've given you. And that comes from the Cochrane review, right? And that footnotes explain everything. Okay, and this is for children. Here, the certainty is low to do a thing for children. So you have this thing called assumed risk and corresponding risk. Very briefly, I'll tell you what it is. The assumed risk in the control group is the average in the control group if the risks are similar across trials. If the risks are very different across trials, you will take the median risk. That's the control group risk. Okay. And for the outcome, the average risk in the control group or control group event rate is 0.22 or 22% or 222 per thousand. That's what the thing is. Corresponding risk with artisanate is to get the corresponding risk, you take the assumed control group risk multiplied by the relative risk and express it as 1,000. That's how you get the assumed risk. Okay. So this is the way you will do this. Yeah, you can, I'll give you these things. Recommend articles. So what you find that done this. Now the people who are actually going to use have to other proof. Plus, plus all the outcomes recommend on the balance of harms cost. That's what they suggest. Strong recommend. Most people will have no problem in recommending. Some people have some doubts for the cost of harms or whatever. And the state. That's how. So what you have to keep in mind is that you provide judgment for putting own data, our own judgment, value that you make the judgments, harms, and in terms of desirable impacts. A very example of use. Government of Ghana wanted to advise them. So they are using by then WHO obviously updated that highly participant reference strong recommend nice on their like so called Cochrane's the James Sinclair from the infectious disease group who actually was part of the guideline process, the WHO. So he went and sat with them and they looked at the local and national evidence and they published that in a paper saying government policy is we will keep artesunate on our list, but we will not use it. We will continue to use quinine because artesunate may have relative benefits over quinine. Quinine is also effective. The local data and global data say quinine work. Right. Quinine is cheap, easily available. Everybody knows how to use it. Artesunate is very expensive, and if we want to switch to artesunate, we will have to reduce funding somewhere else, and somebody else will die. So there's an opportunity cost to switching. We know the evidence is good. Moreover, we don't make artesunate, right? And global supply chains are unreliable. So if we switch entirely, we are in trouble. So that is an example of evidence informed. There is good evidence, you can recommend it, but for us, these are our constraints. It can change, right? So if you're not using it, there's a policy document that we have been through the process and we have made this decision. Okay. There are a lot of resources I can give you. Go to the ICMR website, you will find the Index TB guidelines. Dr. S.K. Sharma from AIIMS and us, we work together with the WHO also. And this is a guideline made by UNAIDS on TB. Like said in the morning, the first version, all the experts came and wrote chapters for textbooks. We said, no, no, no. What are the questions we want answers for which there's controversy? Questions were, how long do you treat spinal TB? Do you add steroids for pleural things? These are the questions for which there were controversy. We found or updated or did systematic reviews to answer those questions and the evidence process. So if you want to know how to use it, this is a good document, gives you everything. Then during COVID, we found there was contradictory evidence on from everywhere, including the government. So our group got together with the Infectious Disease Society of India and did systematic reviews on every one of those topics. They're still available. They'll soon be published in one of the journals. Handbook, as you know, grade as you know, this is from the Cochrane training group. On any of these, you go to all the grade material you need. Okay, and there are many guidelines and stuff. So I want to leave you with my last talk. Half an hour professor will take. I'll sit here. I just want to give you an example of this man. Does anyone recognize this man? He's Ian Chalmers. He is the person who founded the Cochrane Library. And some time ago, he was made Sir Ian Chalmers. And when you become a Sir, right, you get your portrait hanging in the National Portrait Gallery. So Ian met us at one of our meetings and he asked all of us, hey, I'm going to be retiring soon. I need a photograph of you. So all of us sent him photographs and all of us were with Ian Chalmers in the National Portrait Gallery. Right, I can show you, that's me. At his feet. What an honor. So the example I want to give you, because you guys are eager, right? Research is about collaboration. And he said we would never have had Cochrane become so good unless we were a collaboration, right? It's not competition. If my colleague has a paper, I should not feel I'm a failure. Good. I also should do if you want. With that, that's it. Ideas there. Listen, I will answer.
On the behalf of committee, I would like to thank Dr. Mark for a wonderful talk. Thank you very much.
Now, we had considered this part, all cause mortality up to 120 days. Number of participants were 485, and there were three included studies. So when you go on to, we had already graded that in the morning, as well as a part of it in the risk of bias day before yesterday. We know that the risk of bias was serious inconsistency was observed, indirectness was not serious, imprecision was serious, and publication bias was undetected. These are the three things which we had alluded to when we had shown the table which had 5 domains on one part and 3 domains in the other slide. This is the same thing that Sir was discussing on the likelihood or when we can upgrade the evidence. We talk of upgrade the evidence not over and beyond the 5 domains or the 4 direct sum measures. Remember this thing. Since we start low, this is the reason we have the opportunity to upgrade. We cannot go beyond the high level. It's not like high, very high, supreme. It's like since we are starting at the level of moderate, this is what occurs. So just as soon as you write this thing and click apply, there are two things that you need to see. I said apply. It says explanation is required so that others can understand the rationale of your decision. Please add explanations to downgraded certainties. This is what each and everything should be elaborative in nature. This is the component which ensures transparency. What you did, whether it was right or not, or what is the justification, what you did not do, why you did not do. I said I'll explain it later. I did not enter the explanations. Now it's showing me an error mark here. But despite of the fact that I have, written my opinion, not showing me the certainty. Remember that this is extremely common. This happens because of the interface. So just go on to, is it happening with you? You- That may be because of Mac and Windows. You have the RM5 file with you. So what is the problem? आपने इंपोर्ट किया था, नहीं, यहाँ पे पहुंचने के बाद जो सर्टेनिटी ऑफ एविडेंस वाले इस सेल पे आइए, इस सेल पे आके इसको क्लिक करिए. आपने नहीं, आरएम फाइल आपके पास नहीं है. नहीं, आरएम फाइल तो आपको अपने रेफरेंस से जो अभी तक आपका कल और परसों में वो हुआ था उसके साथ आरएम फाइल. I'll also show you the method if you do not have the RM5 file, how to proceed. Okay. Those you have the files, follow this process. Okay. We'll then see if you do not have a file, how to go about it. Okay. The issue here is when you know click this section, it does not specify the study design. So you have to specify that this was a randomized trial. And when you say apply, it immediately takes up the evidence, the certainty of evidence. Okay. So whenever you face this problem, you see that this is very likely happening at most places, that you need to define the design at that point. Okay. I'll go back. How can we add an explanation to it? You'll click this error. It says no explanation was provided. I'll click it. This is empty. I say add new. We had listed a couple of reasons. Okay. I say we have, just for the sake of adding it, I say save. So now it has given it a superscript as an explanation. Similarly, I'll go to the other one. If the explanation for this is kind of same for the other risk of bias statement, you can use it. Otherwise, you say add new. I'll say WER, save. The error message has gone. Go to imprecision. So now we do not have any errors. I say apply. Now it shows that the evidence is very low. What did we see with the paper here? Saw that all cause mortality was there. We had the relative risk 485 and a very low evidence. Okay. The part of the comments is this: the evidence is very unlikely about the effects of the systemic corticosteroids on all cause mortality up to 120 days. Suppose this was the comment that you had decided to put in. What happens? Tells you sides of effects. Say, will that affect or not? You want a narrative statement, yes or not? What happens? Evidence. If you say apply, it will write that the evidence is very uncertain about. So once you have done that, what you can do? What do you want to do once you have prepared this list? Yes. I want that the summary of findings table is made. So you have an edit section which give you an insight into the type that was a dichotomous outcome. We are using the pooled measures. So this is fine, not an issue. Keep it on save. This is the part I hope everyone can appreciate. You have a marker which is placed here. When you click this marker, it show you what is the type of presentation that you wish to see. Summary of findings table version 2, version 3, version 4, an interactive summary of findings table, a grade profile, and summary of finding tables per se. So the kind of absolute versus relative effects that we have been seeing, it is generated as per this thing. What sir showed you, that you have an absolute effect, you have a relative effect. The summary of finding table, the type of table that you want to export will be done from this. Once you have selected the type from here, so guys, let me click summary of findings table version 4. So what this has done is, this has changed the layout slightly. This is the relative effects. This is the patients. Just try to compare. I'll go back to 3 and appreciate the difference. Go back to summary and findings table. So these are the various formats. This is the anticipated absolute effects. The relative effect precedes the anticipated absolute effects. So this is how they give you the difference, or the way you want to communicate the evidence. You can choose as per your style. So once you are done with this thing, and I'm purposely not filling the upper row. You have an export option here. This is the export table option. I'll click on the export table option, and as we have discussed, I do not want a 30-day mortality. I just want 120-day mortality. Now, as has been told that You can use this thing. This is free of cost for non-Cochrane reviews for generating the summary of findings table. For the purpose of completing the workshop, what we'll do is we'll select .sof. SOF stands for summary of findings. So this is an SOF file. We'll download this file. I'll come back to this in a moment. I'll go to my downloads. And in the downloads, it shows me this is the systemic corticosteroids for the treatment of COVID-19 .sof. We have this file now with us. Suppose you did not want, you were not interested in this thing. You said that I just want to have a PDF of this thing or a MS Word copy, which I can edit at my own wish. I can change it accordingly and obviously not tinkering with the results. Okay. So you can select MS Word and export. Then check in. You can select PDF, export. You have the option you want to have the landscape or the portrait mode. They download. As soon as the file is downloaded, you can incorporate the same table in the PDF format wherever you wish to incorporate. In longer than usual time because of the internet connection. This is how you can move ahead and export the summary of findings table. In the meantime that it is doing its work, what we'll do, we'll utilize the time, open the review manager. If you are already having a RM5 file, you can directly open that file. You can customize it. So what I'll do is I have my RM5 file. I'll click on the RM5 file. It will open the interface for me. Once the interface is in front of me, what I'll do is I'll go to the leftmost pane, double click the table section. So you have three parts to it. That is characteristic of studies, number one, summary of findings table and additional tables. I'll click on the summary of findings table. It says add summary of findings table. Okay. ये आपके पास जो RM5 फाइल है उसमें आप डायरेक्टली भी कर सकते हैं. You can directly click on, double click on the RM5 file. It will open, Revmin will open it for you directly. So when I say add summary of findings table, ask me that import the table from a file created in Grade Profiler, or you can create the table using Revmin's table editor. So since we have already done our work, I'll say that I would import it. So in the download section, I had that file. Just a huge number of files. So I have this file which was prepared on Saturday, 16th November, 1421. Okay. I'll open this. Give me the interface. I'll finish it. And this is how the summary of findings table comes into the requirement. Okay. Now the important part is now you have learned how to prepare it in the grade group, how to transport it, that is to the downloads folder, and then import it in the summary of findings table. Okay. So now you have the outcomes. Now what happens is Many a times we are careless. I am also careless. There are spaces. What happens? The evidence is very uncertain. So this table you can directly go and edit it just as you would have done on a Word file. Okay. So we had some issues. All cause mortality. The word is not right. Maybe it is in the in a hindsight. You see the explanation that I have written is probably not the correct explanation. I want to revise it. You do not want to go back to the grade pro and do this thing. So we have a grade pro, that is a grade pro GDT, that is a guideline development tool. So you can change if there is anything here also. So this is the beauty when you are exporting the file to downloads and importing it back to Revmin, you can do so. Okay, I hope this is fine. So let's see if we have the PDF file with us now. Yeah, it has now loaded. So this is the PDF file it has generated. Okay, let's go back. Consider one more scenario. And this scenario is just as a lot of people, they're facing problems with their RM5 file. Suppose you are working on a comprehensive meta-analysis software, or many a times in R, you cannot directly utilize, you have to use a software which prepares a compatible file. You cannot do so, but you have the results and you want to grade it. What you can do is you go back to your personal workspace. So we started with this import project. Everyone is fine. Now, if you have your Grade Pro software open with you, just move as I am moving. I'll say I'll start it with a new project. I give this project a name. Not allowed. I'm creating a new project, that is steroids in COVID-19. I create this project. आप डैशबोर्ड में नहीं जाइए, my personal workspace. You click on your own icon, it will show your personal workspace from there. You log in if it is an issue. Done. क्लिक करिए. हाँ, ये तो आपने कर लिया ना. हाँ, अगर आप उस पे जा रहे हो, you can go to that. So what is our question? Our question is about intervention, whether or whether steroids reduce mortality. Other questions are whether methylprednisolone versus dexamethasone, which of the two is better. You can add a diagnostic question and you can import questions. This is the second place where you can import the RM5 file. You can do it directly from the first interface, from this interface. So since you do not have the RM5 file, no issue, we'll add a management question. So what is the intervention? The intervention is steroids, comparison, standard of care, and let us be explicit in writing that we are not depriving the patient of the standard of care. For the problem here is COVID-19. This setting was patients in ICU or those who were hospitalized. So the authors are all participants. So right to be all workshop participants. So what we'll do, once you have, when you create a project, it will ask you that you have to select a question. So you have three options: add management question, then add diagnostic question or import questions. If you click on the add management question, you'll get this interface. Yeah. So when you do this thing, remember that you have a save button here. Okay. You click on save. Now your question is prepared. We are on the same page mentally as well as on the website. Okay. So this will show this kind of a table that is prepared. Outcome, number of participants. So now what you have to do, we have, sir, उसमें first page पे नीरज आप, so once you have a basic layout with you can add the outcome. If at the outset you want to see which layout you want, you can select the layout from there. We usually are sticking to version 3 or version 4. So you can add an outcome here. So what is the type of outcome that you have? You must have gone through these things. Whether this is a dichotomous, we are looking at mortality at 120 days. This is a continuous outcome or a dichotomous outcome or something else dichotomous side. So what is the, how are you using the data here? Pooled, not pooled, range of effects. What are you doing? So we have done that. And now there's a save changes button. I'll save that. So a part of it is covered, and in the section of new outcome, what is the name of outcome? So outcome is death. Okay. The short you can write D120, that is death at 120 days. Okay. So follow up that we are considering is 120 days. The study design, what we had included 3 studies that were RCTs. Number of studies were 3. What was the intervention total? कितने interventions के हमारे total थे? 285. Yeah, total 485 here. So let us go directly to the analysis. Give you everything. So we had 244 in the intervention group and 241 in the placebo group. We'll apply. तो आप, you just select, we are getting, नहीं नहीं, if you are getting a different type, when you do this thing, then you've done this thing, then you save this, save the changes. Yes. No, no. Hey, this different format is because this is what I'm telling you. The format that you have chosen is incorrect. This is the summary of findings version 3. Now you have all the outcomes in, मैं दिखा सबको दिखा देता हूँ. A lot of people are having problem because they are not selecting the correct format. Please look at the last column. it is showing you the tabs, और उस tabs में paid evidence profile है, summary of findings table है, and you have summary of findings table version 3. This is what I am telling you repeatedly. Select the correct format. Okay. And as soon as you select the correct format, it will show you all the things. Okay. So now what we have to do, we have to plug in two basic values. Controlled event rate again comes back, and it will haunt you throughout your meta analysis. Remember this thing. So we do not have the data, and we have thought that we'll plug in all the data ourselves. We'll click on 0%. In the controls, how many people had event? So in the controls, 97 out of 241 had an event. We'll add 97. Immediately calculates it at 40.2. Let us see, are we on the same page? क्या हो गया सर बताइए? So what I'll do is, let me and then I'll come to your. I'm adding one more outcome. So that I'll say I'll add one more outcome. It asks me whether it is a dichotomous outcome or not. It's a dichotomous outcome. We're using a pooled estimate, and you do not click here. You go and save the outcome. Then you save the outcome. ठीक है, जब आप सेव कर लिया आपने, then you click on the individual cells. These cells are clickable. और विद स्टीरॉइड्स एसओसी और डिफरेंस कुछ क्लिक करने की जरूरत नहीं है. सी या रिलेटिव रिस्क डाला, बाकी ये ऑटोमेटिकली कैलकुलेट करके आपको बता देगा. So you do not have to do a lot of work. Fine. So I'll go back to the outcome. So we said with steroids plus standard of care, it was 40.2%. Look at the relative risk. So it gives relative effect. Why? We have to see whether we are using relative risk, odds ratio, hazard ratio, rate ratio, or any other thing. So what we were using was relative risk. What was the relative risk in our study? It was 0.74. So let us recheck so that we do not commit a mistake. Yeah, it is 0.74 and the confidence interval is 0.23 to 2.34. As soon as you plug your data, both these columns are automatically filled. Okay. So you need to remember that minimum energy you have to invest, rest let the software do its work. So we are here with the data that RM5 file would have given you. ठीक है, तो अब हम मैनुअली प्लग इन करके यहाँ तक पहुंच गए. आगे की जो प्रोसेस है सब सेम रहेगी. तो should I walk you through that process again? Okay. तो इसको ये वाला जो हमारा है, so that it is not creating confusion, I have deleted the outcome. Whenever you delete the outcome, it always asks you, do you want to undo that? Was that by mistake? Is it yes? That was a mistake. I genuinely want to delete it. I'll again delete it. So we have that at 120 days, we have our data plugged in. Now we are here at the certainty of evidence. These studies, Idalatifard, Geronimo, and Munch. We knew that the risk of bias here was serious. You remember this table? I'll go back to the table just for the sake of reference. This was the ROB. This was the ROB 120 days. Okay. The study by Munch had no problems. There were problems in 2 domains. There was problem in 3 domains. So the overall certainty of evidence in this case for the risk of bias was serious. For the inconsistency measure is a heterogeneity measure. Risk of bias is a measure which looks at the individual aspects, right from enrollment, allocation concealment, and other methodological issues. Inconsistency is a heterogeneity parameter. Indirectness is a measure which compares the population, interventions, comparators, and the outcome. It found that that was not serious. Imprecision was definitely serious, and there was no publication bias. So, as I said, now we had filled it ourselves. We started from the outcome to this place. So, as soon as I do this thing, I'll click apply and says again add explanation later. So, if this is a problem with you, you do not want that such pop-ups, disturb your workflow. You can go back to there are three, tabs, one with an icon, one with a setting section, one with help. You go with the settings section, you see forced explanations, always display cautions, drop area. If you uncheck this force explanations, it will not force you to write the explanations. It's always good to have it checked so that you do not leave it by mistake. लेकिन आपको लगता है कि ये परेशान कर रहे हैं तो अनचेक कर सकते हो ठीक है so there is a way to handle this thing it will anyhow show no explanation was provided let us not keep it in this state and we say that the risk of bias if you want to add that we have written the explanations and for the sake of completing the table we'll say for the first part we had downgraded it for serious risk of bias we move back we add an explanation and when we have done we save it it gives it a superscript a go on to the second one this is not the same which is to be done for that go back to the master file we add that save gives a superscript d so what it is making the footnotes of the summary of findings table go on to the imprecision I want to add one more go back to my master file save and now you do not have any errors okay I apply you have a very low evidence now let us check what we saw here in the summary of findings table at page 5 is there something that is missing so things are covered and sorted you want this to be copied as well right paste and it's done so this summary of findings table is complete the next step that you would like to do is if it is in the correct format I'll repeat do check your format from this drop down if it is fine this is the section which is export table I'll सर मैं अभी बता देता हूँ अभी मैं आके दिखा this is the export table click this is the outcome depth utilize another format so we have covered the workable formats the most common being SOF followed by MS Word and followed by PDF it's done so in your downloads you have हमने पहले SOF फाइल एक्सपोर्ट करी थी फिर हमने PDF फाइल एक्सपोर्ट करी अब हमने वर्ड फाइल एक्सपोर्ट कर दी डबल क्लिक दी वर्ड फाइल दी simplified you can actually sit down in the evening write a protocol and from tomorrow you can start working on your meta analysis Any questions in this regard? Kind of the mixed methods approach. What you are doing is a parallel group. That is a separate method altogether. When you're using a separate method, define all the kinds of types of RCTs or the type of studies that you are taking. As of now, it's supposed to be RCTs or a one homogeneous type of study. So when you are going here, I'll show you the drop down so that you go to the outcome. With the outcome, giving you the study design and these studies. So you can, as of now, check either one of randomized or a non-randomized. Non-randomized study or whole interrupted time series, cohorts, any other type of observation. As of now, sir, if you have a question, what I know is that this grade does not allow you to perform a mixed methods analysis by selecting both of them. It does not allow. So you have to either go with the observational or with the RCT.
You can, if you want to do it, you find there's no results.
Yes,
Calculate it like you
it's similar to what you do with, you have a different effect measures. You have millimoles, you have gram percent, you include them. When you do a SMD, standardized mean difference, this is the method when you are using, when you are trying to combine two different types of studies with two different designs.
mean. Because there are two ways people interpret. Mixed methods will be I have a review which is incorporating qualitative methods and quantitative methods and trying to integrate them. You cannot use grades for that. When you're talking about network meta-analysis, some people say mixed treatment meta-analysis. There is a grade for network meta-analysis. You can get that. There's a Prisma document for meta-analysis, and there's a whole grade process for that. Then, if you are using qualitative evidence, there's grades qual, so qualitative studies. So, if you keep those things separate, because all the computations are meant for that particular model. Diagnostic accuracy study also is a grade. One thing I just want to add is, did you show them continuous variables? Because there is where you have to give much more better explanations. We are using a scale. You have to write in that column. We use this scale. It goes from here to here. And high scores mean what? So people can understand. And what time did you apply the scale? What is the timing of when did you use the scale? Apply the scale. The third thing is that you said you will create a summary of findings tables in your review. You gave 5 outcomes or whatever. And you only have meta-analysis for 2 outcomes. You still have to create outcomes for those 5 and say no data available.
As I said, we are adding an outcome. So looking at the we are doing is we are taking an outcome in the name of weight loss. We'll try to measure weight loss at 12 weeks. Like we've kept the name for the sake of simplicity, the weight loss at 12 weeks. When we are saying the length of follow-up, it'll give you all the options. What is it that you want? Mean, median. Suppose we'll keep it median. The length of follow-up would be 12 weeks would be 3 months. You can write in months, you can write in days. See the drop down menu, you have days, weeks, months, years, patient years, and others. The unit that suits you best, depending upon the amount of precision that you want, the data that you have, whether it contains that amount of precision or not, this will be your call. Suppose if everyone is reporting in terms of the short term mortality as 7 days or 30 days, you find this data very clearly. But if you say, I want to see a mortality in terms of week, then if someone is reporting it in less than 7 days or not in terms of week, that would be a problem. So this is something that you have to be careful about. So when you're looking at data, so this will be how many days these would make? It's 90 days. Now, what is the measure that you would like to have? You had your class yesterday. What is the measurement for weight? What is the measurement you want to take? Ordinal? Hmm? Ordinal is used for what? Oh, we are looking at the continuous variables. जब हमने आउटकम सिलेक्ट किया था तो आउटकम सिलेक्ट करते हुए हमारे पास डायकोटोमस था. If there is a confusion, I'll close this window. I'm adding another outcome. Okay, just be careful. सर एक बार इधर से देख लेते हैं ना. I am trying to add an outcome which is continuous in type. Save it. ठीक है, तो इधर डायकोटोमस का ऑप्शन नहीं है. ठीक है. Now you have this outcome. When you click this outcome, what is the problem when you're trying to measure the weight? We discussed this in our earlier class also. Someone might measure it in, और अभी तो यहाँ पे ये है कि कैसे हम मेजर कर रहे हैं. सपोज एक ग्रुप मेजर कर रहा है किलोग्राम्स में, एक पाउंड्स में कर रहा है. फिर विद इन द किलोग्राम्स कुछ लोग ग्राम्स में सेग्रीगेट करके कर रहे हैं. तो यूनिट ऑफ मेजर जो होगा, यू हैव टू डिफाइन इट एक्सप्लिसिटली. और अगर अलग अलग आप डेटा कैप्चर कर रहे हो तो उसमें इंपॉर्टेंस है. अगर आप में जैसे पाउंड्स के साथ तो 2.2 से अगर आप मल्टीप्लाई कर दोगे तो आपके पास कन्वर्जन है. There is a possibility you may have units of measurement when they cannot be converted directly. So the measure of effect that you would like to use would be something that brings them all at one level. Take it mean 90. And so this would be. अच्छा, what is an ordinal scale? अगर आपको एक confusion है, suppose I am looking at a scale जैसे Likert scales होते हैं. Ordinal का क्या मतलब? Something which is ordered, and the order tells you the magnitude also. It is different from nominal, because nominal, if it is like a blood group, A, B, O, AB, in whichever order it is, but it is the same thing. Does not tell you one thing, any other thing. When you have a ordinal scale, it tells you an order. So higher the order, the likelihood you may have more problem. Likely, probably, definitely, I'm not sure, neutral. So these are the ordered. In psychiatry, in psychology, and some part in neurology also, we are using all those scales. So it is a different form. Okay. If you are using an ordinal scale, you're using this thing. Now the conventional lower and upper one, limits of scale. What it is not showing. वाई नहीं, लिमिट्स ऑफ स्केल तो इसके अंदर आएगा ना, आपने रैंडमाइज किया, नंबर ऑफ स्टडीज आपने इसके अंदर कर दिया। करिए। If you are not finding that, you can define the limit here. Okay. You plug in the study design many a times, as I had shown when I was importing the data. If you have not defined the study design, it will not show you anything else. And then in the intervention in the control arm, the total sample you can apply, and this is how things will go ahead. You can do so similarly if you want to go back, ordinal scale, range of possible scores. तो आपके पास क्या है, सपोज 5 स्टेप का स्कोर है, जैसे मॉडिफाइड रैंकिंग स्केल है। यू हैव अ मॉडिफाइड रैंकिंग स्केल, आपने ग्रेड किया 0 to 5 पे। मेनी टाइम्स अगर आप 0 यूज करते हैं तो क्वांटिफाइबल नहीं होता, सो यू कैन यूज द रेंज ऑफ पॉसिबल स्कोर्स फ्रॉम 1 to the 5। और उसमें जब आप मीन मीडियन यूज करते हैं, रेंज यूज करते हैं, दिस इज हाउ थिंग्स चेंज। दैट मेक्स सेंस? ओके। You can revise that and see